projects, prestigious collaborations from NIH, MRC, UK, DBT. She has developed validated culture-sensitive screening diagnostic instrument for autism, ADHD, epilepsy, neuromotor impairment. Autism certification has been initiated over here. Training of master trainers by MOSJE has been done. Many of the mobile applications are loaded in our website for free use. Drug refractory epilepsy, she had been involved in novel dietary therapies. In autism, she has been involved in molecular biomarkers, etiopathogenesis, and many of the RCTs. Neuromuscular disorders, there had been many innovations where we had also taken up skin biopsy to replace muscle biopsies, and many of the RCTs are underway. One of the main RCTs includes atalurin and few of the others which Dr. Shifali would definitely put light on. She has developed pediatric neurology as a specialty in India and has been instrumental in transforming care for children with neurodevelopmental disorders pan-India. Her contributions are definitely noteworthy. Today I welcome Dr. Shifali Gulati to present the first topic, Approach to Neuromuscular Disorders, Clinical Suspicion, Diagnosis, Evaluation of SMA and DMD. Ma'am, over to you.
Thank you. Thank you, Kakule. Welcome you all to the series of webinars which have been funded by Global Genes. And this is basically been for financial advocacy of the rare diseases, and we had applied for basically concentrating on SMA and DMD. The reason being that these two these two disorders have latest, a lot of advances in the therapeutics which have come up, and because of which there has been, there's a lot of debate going on because most of these medications are very expensive. So what we have thought of is we have planned the series of webinars. We'll be having 20 webinars spanning from today to 3rd. And I apologize for the start of a delay because there was some problem in linking with YouTube and all. And so there's a technology getting some hiccups. And what we have planned is today we'll be talking about how do we approach neuromuscular disorders and how do we arrive at a diagnosis of DMD and SMA, and then what are the current therapeutic advances. Basically because we are catering to parents as well as professionals, so I will also be speaking with Hindi and English. So basically aim of the series of webinars जो हमारे को Global Genes ने support दिया है is basically aimed for financial advocacy for DMD and SMA. These both are the commonest of the rare diseases हैं, और उसके लिए बिकॉज नया ट्रीटमेंट अवेलेबल है तो उसकी वजह से हमने सोचा कि इन दोनों के ऊपर फोकस करें, और इसके ऊपर से हम पिछले 30 साल से भी काम कर रहे हैं, तो इसीलिए इनको हमने DMD SMA में फोकस किया है. तो हम शुरू में आज बात करेंगे कि उसकी अप्रोच क्या है, कैसे डायग्नोसिस करते हैं और कैसे उसका मैनेजमेंट करना है, होलिस्टिकली मैनेजमेंट उसके ऊपर करेंगे. उसके आज स्लोली कि वी विल बी गेटिंग यू, आपको पूरा प्रोग्राम भेजेंगे जिसके अंदर टॉकिंग अबाउट द रिसर्च गोइंग ऑन, क्या उसके फाइनेंशियल सपोर्ट है, इंश्योरेंस थिंग्स एंड फ्रॉम द फार्मा, फ्रॉम द रिसर्च एजेंसीज. तो इन सबके ओपिनियंस क्या है और कैसे वी कैन come up and bring everything, all the newer treatments available to the common people. ये हमारा basically is the aim, that is the aim to do it. So we will be having primer जो शुरू में है, आज जो overview है वो मैं दे रही हूँ. उसके बाद we will be having many people from India and abroad who will be joining us in various discussions to take it forward, because ultimately हम सबका aim ये है कि हम लोगों को बेसिकली सब बच्चों के पास एक तो हमें डायग्नोज जल्दी करना है, फिर हमें उनको ट्रीटमेंट प्रॉपरली होलिस्टिकली कंप्लीट देना है, मल्टीडिसिप्लिनरी, फिर भी नई दवाइयां हैं उनको ले जाना है, और प्लस क्योंकि मोस्टली ये जेनेटिक, ये दोनों बीमारियां जेनेटिक हैं, तो उसके लिए कि उनको जेनेटिक काउंसलिंग, और ताकि दोबारा एक ही फैमिली में जब दो बच्चे होते हैं तो वो आई फील इज़ अ फेलियर ऑफ द मेडिकल फ्रेटर्निटी. हम सबका फेलियर है अगर एक फैमिली में दो बच्चे हैं जब हमें मालूम है कि वो जेनेटिक प्रॉब्लम है. I'll just start sharing my screen, and I will be, one sec. Can you please allow me to share my screen? Screen share. Please allow me to share the screen. Please allow me to share. Yeah, thank you. Can you please check whether my screen is visible? Yeah, okay, fine. Okay. So basically, we will be talking about approach to neuromuscular disorders, focus, DMD or SMA. I have no known disclosures. Basically, any problem which is coming in the motor unit, whether it is in the anterior horn cell, whether it's in the anterior horn cell, nerves, neuromuscle junction, or the muscle, or back to the nerves, anything going wrong or anything coming from the brain, कहीं पे भी मोटर यूनिट में प्रॉब्लम होने से हमारे को न्यूरो मसल प्रॉब्लम हो सकती है, वीकनेस हो सकती है, चाहे एंटीरियर हॉर्न सेल है या नर्व्स है या न्यूरो मसल जंक्शन है या मसल है या नर्व्स अगेन. तो बेसिकली एंटीरियर हॉर्न सेल के इन्वॉल्वमेंट इज गोइंग टू कॉज स्पाइनल मसल एट्रोफी कैरेक्टरिस्टिकली. एंड जो दूसरा हम बात कर रहे हैं मसल डिस्ट्रोफीज डीएमडी की, वो मसल फाइबर इन्वॉल्वमेंट. सो बेसिकली टॉकिंग अबाउट एंटीरियर हॉर्न सेल प्रोटोटाइप स्पाइनल मस्कुलर एट्रोफी एंड द डुशेन मसल डिस्ट्रोफी. Basically, when we suspect a neuromuscular disorder, we first see the child clinically whether predominantly proximal weakness है या distal weakness. Depending on whether their weakness is proximal or distal, we are able to think about certain things, and we are able to think in our brain which part of the system is involved, and then whether your reflexes are absent, tongue fasciculations may be there, and a relatively static course. That is how you see in an anterior horn cell disease. And in a muscle disorder, you may have weakness outside the muscle also. तो बेसिकली हमारे को बेसिकली देखना है, बच्चा आया है उसको वीकनेस है तो प्रॉक्सिमली है कि नहीं, कि हमारे को या हाथ पैर में पेरिफेरली है, या पे अगर हम लोगों से बैठना उठने में प्रॉब्लम हो रही है और शोल्डर में और हिप वगैरह एरिया में है, उस हिसाब से वी सस्पेक्ट. सो बेसिकली दूसरा एक एस्पेक्ट हमें जब ओपीटी में पेशेंट मिलता है वो फ्लॉपी है, मतलब वो ढीला ढाला है. द फ्लॉपी चाइल्ड, वेदर द चाइल्ड विल हैव अ poor muscle power and a depressed reflexes, or the child may have a brisk reflexes and retained power. So उसमें क्या है कि when the power is reduced and the reflexes are diminished, तो फिर वो peripheral होता है hypotonia, and if it is brisk reflexes and all, this central hypotonia. Central hypotonia will be caused by something in the brain, and peripheral hypotonia will be caused anything in the motor unit. But one thing I want us to remember, that you may have a mixed picture, because a child who may be having a central hypotonia due to some reason may be having also a peripheral hypotonia. So basically somebody may have had a delayed cry, somebody may have a malformation of the brain, तो उसके हिसाब से it can be missed. सो बेसिकली अब फिर चाइल्ड हमारे को ढीला मिल रहा है तो उसके हिसाब से हम सोच सकते हैं कि उसकी वीकनेस मसल की वीकनेस है या उसके अंदर और एसोसिएटेड प्रॉब्लम्स कुछ हैं, जिसके हिसाब से वी कैन थिंक अबाउट द कॉज एंड द डायग्नोसिस. Basically, whenever we are approaching a child with suspected neuromuscle weakness, we have to always think in mind the age at onset, what is the clinical pattern, and what are the involvement outside the skeletal muscle. Disease course kya hai, what is the mode of inheritance, and what can you do to arrive at a diagnosis, and any treatment options kya hai. We are nowadays only focusing on the definitive treatment options which have recently come up, but we are forgetting the multidisciplinary supportive management. तो जब भी बच्चे को वी आर थिंकिंग कि बच्चे को कोई न्यूरो मसल प्रॉब्लम है, तो इसका एज कब स्टार्ट हुआ है, क्लिनिकल पैटर्न क्या है, उसके मसल्स जो है वो क्या इन्वॉल्व है, मसल्स के बाहर क्या वीकनेस है, डिजीज कोर्स क्या रह चुका है, इनहेरिटेंस क्या है, और उसके साथ में क्या हम डायग्नोसिस कर सकते हैं. और ट्रीटमेंट के लिए जो नया ट्रीटमेंट है वो सही है, लेकिन हमारे को मल्टीडिसिप्लिनरी पूरा होलिस्टिक सपोर्टिव केयर को देखना जरूरी है. When we are approaching a child, we are obviously seeing whether it's a neuromuscle problem and whether anywhere motor unit may where it is going to be localized to, and what is whether there is any hereditary cause, whether it's acquired cause, whether it's static or progressive, and what are the possible causes and the functional status of the child. तो एक बच्चे को पूरे रूप से देखना है कि क्या क्या प्रॉब्लम्स हैं, क्या कारण हो सकते हैं, एंड उसका क्या फंक्शनल एबिलिटी है टू अंडरस्टैंड. और जो जनरली टेस्ट हम न्यूरोमसल डिजीज में करते हैं वो क्रिएटिन काइनेज, वी आर वॉट एवर वी जनरली डूइंग आर क्रिएटिन काइनेज, वी डू इलेक्ट्रोडायग्नोस्टिक टेस्टिंग which has EMG, our repetitive nerve stimulation, nerve conduction testing depending on the case, imaging which we will be detailing, and exercise testing when we are suspecting metabolic disorders. तो generally speaking पहले हम start करते हैं CK से, फिर EMG NCV वगैरह करते हैं, या RNST डिपेंडिंग जब हम क्या सोच रहे हैं किस बीमारी के बारे में, एंड इमेजिंग के बारे में आपको थोड़ा डिटेल में बताएंगे, और एक्सरसाइज टेस्टिंग जब हम मेटाबॉलिक कंडीशन सोचते हैं. Muscle biopsy, I want to mention, although the number of times we need to do a muscle biopsy has been drastically going down over the last 25 years, maybe more so for the last 10 years. If we see the biopsies which we were doing earlier, now we are not doing that. It is not required because of the approach and getting the which I will be telling you about DMD and SMA, and because we have a lot of genetic tests and all which have come up. But it is important to remember that the muscle biopsy should be done in a center which is well equipped by, who can do not only the normal H&E staining but also immunohistochemistry and enzyme histochemistry and all, because that is important, and you need to have the muscle biopsies snap frozen in liquid nitrogen, and we should not just be doing anywhere who has only H&E, because to specifically diagnose which neuromuscle disease it is, you need to have all these testing done, which can be done only when it is snap frozen in liquid nitrogen. Nerve biopsies, yes, when we are suspecting the nerves and all, and we have when you have other conditions, immune diseases and all, which we are not focusing, you can get antibodies done, and obviously genetic testing has come. तो मसल बायोप्सी का मतलब बस यही बताने का इम्पॉर्टेंट है कि मसल बायोप्सी में जो रूटीन स्टेनिंग करने से ही नहीं है, कुछ स्पेसिफिक टेस्ट है विच आर रिक्वायर्ड, तो उन्हीं जगह कराना चाहिए जहाँ पे ये सारी सुविधाएं अवेलेबल हैं. इंडिया में आजकल काफ़ी जगहों पे ये सारी सुविधाएं अवेलेबल हैं, और जेनेटिक टेस्टिंग अभी काफ़ी उभर के आ रहा है. इमेजिंग की जो मैं बात बोल रही थी, द इमेजिंग हैज़ कम अप, हैज़ नॉट बीन यूज्ड मच, बट नाउ इट इज़ बीइंग increasingly recognized. You can do ultrasound of the muscle, CT, MRI, and the MRI can be either of the muscle or the brain. What happens is when we're doing a muscle imaging, it sometimes in cases of inflammatory pathologies and the acute conditions, you may be able to identify a site of muscle biopsy. Sometimes like in calpainopathies, you have posterior medial compartment involved. So in that you can get an idea, and you may also need for some follow-up when you're doing in studies. That is there. तो मसल इमेजिंग जो है वो अल्ट्रासाउंड, सीटी और एमआरआई कर सकते हैं, और एमआरआई और सीटी ब्रेन की भी है जो बाद में आपको बताऊंगी. वो बेसिकली जस्ट हेल्प्स, सारे में नहीं करना होता, कभी एक्यूट कंडीशन होती है तो उसमें आपको मसल बायोप्सी कहाँ से करनी है वो बता सकते हैं. और कुछ प्रकार की बीमारियाँ होती हैं जैसे कैल्पेनोपैथी, जिसमें कोई पर्टिकुलर मसल ग्रुप्स इन्वॉल्व होते हैं. सो जैसे ये कैल्पेनोपैथी वाला बच्चा है, इसके अंदर पोस्टीरियर और मीडियल कंपार्टमेंट इफेक्टेड है, तो उससे आइडिया मिल सकता है. सो दैट इज हाउ बिकॉज ऑफ द posterior medial compartment we are seeing on the MRI. Ultrasound has been talked about since 1980s, but the point is it is not being used that much, but it is because it is non-invasive and doesn't need sedation and all. So it is important then if we start bringing it up, especially in cases of hypotonic infants. So there is some gradation of ultrasound के जो कुछ gradations बताई गई हैं for various muscle diseases, तो उसके बारे में we have all these grades which are there, and it just needs some experience for any radiologist to understand that. Duchenne muscle dystrophy, in Duchenne muscle dystrophy, muscle ultrasound has been shown to monitor the progression. And I also want to mention that CPK should not be done on follow-up. Many patients DMD patients come up with the CPK levels being done again and again. There, it is not required, and you don't have to do repeat CPK levels. Muscle ultrasound has been shown to monitor progression of DMD in DMD patients. So ultrasound के लिए can be used फॉलो करने के लिए डीएमडी पेशेंट्स का, और कई सिचुएशन में एमआरएस, मैग्नेटिक रेजोनेंस स्पेक्ट्रोस्कोपी, वो रिसर्च में ही किया गया है. तो हम लोगों ने भी स्टडी किया था, 2 स्टडी की थी, एक छोटे बच्चों में की थी टू अंडरस्टैंड इन स्मॉल इन्फेंट्स वी हैड डन अ स्टडी टू अंडरस्टैंड वेदर वी कैन डिफरेंशिएट वेरियस floppy infants. So it had helped us. So it is important that we can start bringing up ultrasound in the forefront. In CMD के अंदर जो है, ये वाला पिछले स्लाइड में है, normal muscle is there which is lot of uh, echoic areas are there. In congenital myopathy, it is smooth, smooth and fascicular architecture absent here, what is there here. And and in this CMD, you may have partial preservation of the fascicular architecture. So we did find some benefits. So ultrasound का कुछ रोल है, और हमने कुछ एक बड़े बच्चों में भी की है, तो 2 स्टडीज भी है, हमने की हैं, तो उसको एक्सप्लोर करा जा सकता है. एंड इन मेनी सिचुएशंस इट कैन बी यूज्ड इन द इनिशियल स्टेजेस. Radiogenomics has come up in a way because it helps, as I mentioned, the MRI, depending on which compartment involved and all. So it is being used basically in many conditions. It helps us, like I told you about that calpanopathy, but it helps us guide in many congenital muscle dystrophies and congenital myopathies. And neuroimaging can be helpful in some cases. Like this was the first patient of Fukuyama muscle dystrophy we had reported long time back from India, in which on the MRI you had this cysts in the cerebellum, and you had polymicrogyria and pachygyria. So some muscle dystrophies, some congenital muscle dystrophies, they have involvement of the brain. And serum, this was a myrosin negative CMD with had some white matter changes. So basically कुछ conditions हैं जिसके साथ brain में affliction हो सकता है, जिसके अंदर हमारे को brain की imaging can help. तो CPK की हमने बात की थी. The CPK is has a very high value which comes for the muscle dystrophies, and we are focusing on DMD and also for some of the inflammatory acute conditions. Or if you do it in somebody who's an advanced stage, where obviously the CPK will go down. So CPK is not required to follow up. Coming to muscle biopsy, generally what we do is when we are doing for a chronic disease, we should do just muscle dystrophies in that, and we should do a moderately affected muscle. In acute conditions, you need a severely affected muscle. Generally, you use the deltoids, biceps and quadriceps, and sometimes we do an EMG in the process. So we like to do a EMG on the right side and the biopsy on the left side. Because if we put the EMG needle and then we are going to do the biopsy, they may have artifactual changes in that area. And also just remember that after EMG, you may have some CPK levels which may be increased. So we like to do a CPK before that. This is just to give an overview of the various stains and all which is required to understand and interpret a muscle biopsy. I feel pediatric neurologists have to have a close listening with the pathologist, and we should have neuropathology conferences where we discuss the clinical and all these clinical and the pathological features. And before that also, when we are doing it, we have to give all our clinical possibilities, because the pathologist cannot put all the stains. So you have just to understand that you can see the morphology, the fiber typing, the NADH, and SDH. You may have glycolytic enzymes, you may have hydrolytic enzymes, you may have storage material like this, which is vacuolated, which on oil red O is showing fat. Then this is a dystrophin associated protein complex is there on the membrane. Anywhere anything going wrong is going to cause a weakness. So there are various molecules which are there, extracellular or the sarcolemma related proteins, which can be stained, and based on their staining we can understand what kind of condition it is. A gross example is Duchenne muscle dystrophy. In this, you can see there is fibrofatty tissue in this, but in this cells, there is nothing lining the membrane. DMT में बिकॉज डिस्ट्रोफिन का स्ट्रेनिंग के अंदर इसमें मेम्ब्रेन्स में कुछ लाइन नहीं आ रही है, आपको नेक्स्ट स्लाइड में पता चलेगा विद BMT. In Becker's, because it's patchy involvement, so see the membranes are highlighted in some and some of them are not. So patchy involvement in Becker's. And then you can have various MHC classes and all, and electron microscopy does have a role. This is the zipper lock thing, or some people call it the parking lot inclusions for mitochondrial, and this all is for a storage myopathy. So you may get help, but in that you have to keep the sample in glyceraldehyde, has to be given separately. All these things cannot be done if a muscle biopsy is put in formalin. That one has to keep in mind. And for the last many years, since around 2008, with Dr. MC Sharma, and we all have been trying to study whether we can replace skin biopsy, can replace the muscle biopsy, because skin biopsy, skin has sweat glands, and sweat gland has muscle, and if you stain that, you can get some idea, and this will help us to understand more so on follow-up of these patients. ये electral pili muscle है, if that gets stains, and you can see for dystrophin staining and all. So we have done some studies in which, and some of them are published, and many of them are published, and we are trying to say whether, especially for new treatments which are coming up for research purposes, it's easier for a parent to allow a child's skin biopsies to be repeated to see the response to treatment than a muscle biopsy. तो बेसिकली मसल बायोप्सी के अंदर हमारे स्पेशल स्टेनिंग हैं, और वो सिर्फ फॉर्मलिन स्टेन के बाद नहीं होते हैं, बाकी सारे स्पेशल स्टेन वगैरह करने हैं. और ऊपर से ये है कि वेदर वी कैन यू प्लीज म्यूट द अदर्स, म्यूट द अदर प्लीज, सॉरी, can you please be there only and mute anybody who's speaking. Yeah, so basically ये हम कोशिश कर रहे हैं कि बाकी जो मसल बायोप्सी में डिफरेंट प्रकार के स्टेन से हमें पता लग जाता है, लेकिन अभी हम लोग ने अनुसंधान से ये बताने की कोशिश कर रहे हैं कि अगर स्किन बायोप्सी करें तो वो भी हम मसल बायोप्सी को रिप्लेस कर सकते हैं, बिकॉज स्किन के अंदर स्वेट ग्लैंड के साथ छोटा सा मसल होता है. साथ में यू हैव वेस्टर्न ब्लॉटिंग ऑन मसल स्पेसिमेन विच कैन बी डन, एंड जेनेटिक टेस्टिंग हैज़ कम अप इन अ वेरी बिग वे, एंड I will be focusing on the DMD and SMA only, because that is what we are focusing overall on. So DMD is the largest human genes with 79 exons, and mutations maximum are cluttered in 2 areas, and there is a high mutation rate, and majority of patients have deletions or duplications. And earlier the multiplex PCR used to be done. Now we prefer to do an MLPA at the beginning. And sometimes what happens is we've had a high CPK and the multiplex PCR will be negative, and then MLPA may be also negative, and then you may like to do a gene sequencing, and that helps in many times, maybe in like nonsense mutations and all, it may be found more after doing. So we have to decide. We preferably advise an MLPA first, and if the MLPA is negative, then you may like to do a gene sequencing. SMA ऑन सो DMD की जो बात हो रही थी कि वो DMD की सबसे बड़ी जीन है, और उसके अंदर कोशिश यही है कि हमारे को क्या पहले हमें MLPA से करना है, MLPA में नहीं आएगा तो फिर हमारे को फिर जीन सीक्वेंसिंग करनी है. Coming to SMA, the SMN gene is on chromosome number 5, and exon 7 deletion is responsible for 98% of patients with SMA. And if you see an MLPA, we prefer to do an MLPA in which, SMN1, we are seeing that copy numbers which are not there, and so it's pathogenic. And we also see for SMN2 copy numbers, and we'll be talking about this more in detail when we talk about the therapies, because they are based on this when we'll be talking about SMN1 and SMN2 to understand because of treatment thing. तो SMA का है कि maximum is because of the 98% now because of exon 7 deletion, and we should do an MLPA के अंदर SMN की नंबर 1 की कॉपीज भी देखनी है और SMN2 की भी देखनी है. इट इज़ इम्पॉर्टेंट. कई बार पेरेंट्स जब आते हैं उनको हम दोबारा भेजते हैं तो वो सोचते हैं हम दोबारा क्यों भेज रहे हैं, दोबारा हम SMN2 कॉपी नंबर्स के लिए भेजते हैं. तो इसलिए पहले जो भी प्रैक्टिस में है, जो भी डॉक्टर्स के पास जा रहे हैं, तो वो पहले से ही अगर MLPA कराएंगे तो दोनों SMN1 और SMN2 पता चलेगा, तो आगे की मैनेजमेंट में बेनिफिट मिलेगा. Coming to the phenotype which we classically see for DMD, you may see calf hypertrophy, and there is differential hypertrophy and atrophy of various muscle groups. So there may be a deltoid which is hypertrophied, infraspinatus which is hypertrophied, and the posterior axillary fold is atrophied. So this Dr. Sunil Pradhan from SGPGI had talked about as a valley sign. When the child ultimately becomes into a adult, and with this person, this child was about 19 years this time, developed a lot of contractures. Depending on the pattern of weakness, which muscle. So if there is the proximal muscle weakness was there, pelvic girdle is involved, and the shoulder girdle is involved, and depending on various other distribution of weakness, we can discuss about various other muscle dystrophies. All muscle dystrophies are not Duchenne muscle dystrophies. You may have LGMD, EDMD, FSMG, distal MD, dysferlinopathies, but we are not talking much about that. We are just thinking that depending on the clinical examination and distribution of weakness and the course, we can suspect these conditions. तो बेसिकली डूशेन में हमें पता है कि काफ हाइपरट्रोफी हो रही है, कुछ मसल बढ़ जाते हैं, कुछ मसल एट्रोफी हो जाते हैं। और बच्चा जब 19-20 साल का ये बच्चे हो गए थे तो इसके बाद कितने कॉन्ट्रैक्चर हो जाते हैं। उसके बाद पैटर्न ऑफ वीकनेस कहाँ कहाँ मसल बॉडी में पूरा है उसके हिसाब से, प्लस बॉडी में मसल्स के अलावा भी क्या फ्लेक्शन है, जैसे फेशियल स्कैपुलर में फेस इन्वॉल्व होगा, है ना, ईडीएमडी में एल्बोज के कॉन्ट्रैक्चर्स हो जाएंगे, तो उस हिसाब से भी हम लोग सस्पेक्ट करते हैं कुछ बीमारियां आगे और उसके हिसाब से टेस्ट करते हैं. सो बेसिकली व्हेन वी आर हैविंग a child coming to us and seeing gradually progressive proximal muscle weakness, there may be a family history, birth history should be taken and development history should be taken, and we see the bulk, tone, power and gait, and then you see, you know, functional evaluation ki how much time does the child take from getting up from squatting on the floor, and doing the various examination for the muscles as well as heart, and seeing the other, you know, even the respiratory muscle examination, like to do a single breath count and trying to see what all muscle groups are involved. So when you suspect all that, and then you do a CPK level, and then CPK level, if it is high, then we will like to do a ideally an MLPA, and then you confirm according to that DMD. But if the CPK level is doubtful and then we would like to you know, we are not clear about it, then we'd like to do a muscle biopsy first. So that is why so many patients don't need, because we are doing on MLPA only. And when you have any suspicion of you know, muscle dystrophy, and your CPK level is not suggestive or MLPA is negative, then we do the muscle biopsy. Or sometimes when the parents are affording, we can do an exome sequencing also directly, and then, you know, then we can also do either a muscle biopsy or skin biopsy, or you can do both of them together. That can be thought about, and depending on this we go ahead. So that is what we have to understand, that we like to do a CPK, after CPK like to do an MLPA, and after that it gets confirmed. But otherwise negative, we'll do a muscle biopsy, or doing a whole exome depending on the availability and affordability. And that if the muscle biopsy is done, and then later on also we'll have to do a whole exome to understand which all mutations are there, so whether they are amenable to any latest treatment. तो बेसिकली हमें जब क्लिनिकली सस्पेक्ट होता है तो उसके बाद बेस्ड ऑन की प्रोग्रेसिव है, प्रॉक्सिमल है, शोल्डर और यू नो पेल्विक मसल्स में ज़्यादा हो रहा है, और उसमें जब नीचे से उठ रहा है बच्चा, उसका पहले तो काफ हाइपरट्रोफी है, और जब ज़मीन से उठ रहा है ऊपर तो अपने घुटनों पे सहारा लेके उठ रहा है, तो जो गावर साइन होता है, तो उसका वो सब देखने के बाद जब हमें लगता है तो फिर वी लुक फॉर कार्डियोलॉजी का और रेस्पिरेटरी एग्जामिनेशन एंड ऑल टू सी कि और क्या कहाँ कहाँ इन्वॉल्वमेंट है, और साथ में CPK लेवल इज़ डन एज अ फर्स्ट, एंड देन वी ट्राई टू डू एन MLPA टू कंफर्म. अगर CPK ज़्यादा हाई नहीं है, MLPA नेगेटिव है, तो वी डू अ मसल बायोप्सी और नेक्स्ट जनरेशन सीक्वेंसिंग डायरेक्टली ईदर वे टू डायग्नोज दीज कंडीशंस. एंड बस ये बताना चाह रही, एक तो मैंने बताया सारी मसल डिस्ट्रोफीज DMD नहीं थे, सो वी हैव टू नाउ अंडरस्टैंड दैट ऑल देयर आर वेरियस मसल डिस्ट्रोफीज विच वी सस्पेक्टेड ऑन द बेसिस ऑफ द पैटर्न ऑफ वीकनेस, grossly speaking. But even in the DMD which is the X-linked one, which has a spectrum of these dystrophinopathies, which can be Duchenne muscle dystrophy, can be Becker's, which is the milder one, and they may be intermediate ones with outliers. You may have DMD associated dilated cardiomyopathy, muscle cramps with myoglobinuria, or you may have asymptomatic elevation of enzymes. You may have manifesting female carriers. So basically सारी जो मसल की प्रॉब्लम जो डिस्ट्रोफीज हैं सारी DMD नहीं होती. हमने वो देखा था पिछली स्लाइड में कि हम डिफरेंट पैटर्न ऑफ मसल वीकनेस से हम डिफरेंट टाइप्स की, जैसे लिम गर्टल मसल डिस्ट्रोफीज या एमरीज ड्राइफर्स, FSFD वगैरह हम सस्पेक्ट करते थे. तो लेकिन जो एक्स-लिंक्ड वाली डिस्ट्रोफिनोपैथीज हैं उसमें भी काफ़ी एक स्पेक्ट्रम है. तो जो हम क्लासिकली देखते हैं और बात करते हैं वो डुशेन मसल डिस्ट्रोफी है, और उसका जो माइल्डर वेरिएंट है वो बैकर्स है, और उसके इंटरमीडिएट आउटलायर्स है. लेकिन कुछ और भी हैं जिसमें सिर्फ हार्ट प्रॉब्लम्स या मसल क्रैम्प्स या फीमेल्स में भी मैनिफेस्ट हो सकता है. सो वी हैव टू अंडरस्टैंड कि इसका स्पेक्ट्रम काफ़ी बड़ा है. एंड जो डुशेन मसल डिस्ट्रोफी के बच्चे हैं, वी हैव टू अंडरस्टैंड दैट वी हैव टू सी होलिस्टिकली एंड फॉर अदर थिंग्स. दे मे हैव प्रॉब्लम्स विद द pulmonary function, and obstructive sleep apnea is very common. तो सारे DMD के बच्चों में पल्मोनरी फंक्शंस भी देखने हैं, और देखना है कि उनके अंदर कोई स्लीप में प्रॉब्लम तो नहीं हो रही, क्योंकि स्लीप रिलेटेड प्रॉब्लम्स काफ़ी होती हैं, जिसमें से ऑब्स्ट्रक्टिव स्लीप एपनिया 2/3 पेशेंट्स में है. साथ में we have to understand that recently we had done a study in which we had looked for the prevalence of vascular, upper gastrointestinal and bladder smooth muscle dysfunction, and that was seen in 27% of these patients. तो बेसिकली हमारे को देखना है कि वो हाथ पैर के अलावा उसके साथ में जो हमारे खून के जो वेसल्स हैं और साथ में हमारा स्टमक और ईसोफेगस है और हमारा यूरिनरी ब्लैडर है, उसमें भी एफ्लिक्शन 27% बच्चों में पाया गया है। ऑल्सो ये है कि many of these children may have intellectual disability or cognitive impairment in up to 130 all of these children, and they may have more prevalent frequency of psychiatric comorbidities and in these patients, and it is important to understand this. And मोस्टली इन बच्चों में दिमाग में समझ सही रहती है, लेकिन 30% में थोड़ा सा दिमाग की समझ कम हो सकती है और साइकियाट्रिक इश्यूज जैसे अटेंशन डेफिसिट हाइपर एक्टिविटी डिसऑर्डर हो सकता है. There is an importance to see the neurobehavioral issues which are there, and this was one big study in which 23% had ADHD and 43% had behavioral problems and 51% had depressed mood. तो बेसिकली हमारे को न्यूरो बिहेवियरल की प्रॉब्लम देखनी है और 23% में ADHD, 43 में बिहेवियर प्रॉब्लम और 51 में डिप्रेस मूड पाया गया है. ऑल्सो हैविंग अ प्रॉब्लम इन द चाइल्ड not able to do what the other siblings and the peers are doing puts a lot of stress on the child. So we have to do a counseling of the child as well as the family, and also put coping strategies. तो बच्चे का जो coping है वो देखना है, family का coping देखना है, because ये stressful बहुत रहता है, तो we have to focus सारे बच्चों के लिए. अब ये देखा जाए dystrophinopathies are basically when we saw data we found 88% having dystrophinopathies. Limb girdle was seen in 6.5% and congenital muscle dystrophy 3.6. Just to have an idea to understand the prevalence of these conditions, so common is 88%, 88% के करीब dystrophinopathies ही होते हैं. The other thing what we're talking about is SMA. SMA के अंदर the prototype is the floppy child who has this frog-like posture, and उनको the child may have a head lag and may be loose to pick up when you're picking up in the hands. So ये floppy ढीला बच्चा जिसको गर्दन भी संभाल नहीं पा रहा है, तो ये this is the prototype how we come up, and there are features which are strongly suggestive of SMA, which may be symmetrical weakness, and trunks and limbs are both affected, proximals are affected more, and fasciculations may be there, and they may be polymyomyoclonus, which I'll be showing in the slide subsequently. And on electrophysiology, we may have some fibrillations and fasciculations with which we can suspect. But the depending on the onset of SMA, you have basically SMA various types which are there, and type 1 is less than 6 months onset, type 2 is less than 18 months onset, and type 3 is more than 18 months onset. तो SMA में ये जो ढीला बच्चा है उसके अंदर वीकनेस होगी हाथ पैर में भी और ट्रंक में भी उसके अंदर, लेकिन प्रॉक्सिमली वीकनेस ज़्यादा होगी, शोल्डर और हिप वाले एरिया में ज़्यादा होगी, और इनके अंदर कुछ फैसिकुलेशन और ट्रेमर लाइक मूवमेंट है जो आपको अगली स्लाइड में वीडियो में दिखाएंगे, और साथ में इलेक्ट्रोफिजियोलॉजी करते हैं जिसके अंदर से कुछ आइडिया मिलता है. अब दिस वन इज अ चाइल्ड हु इज हैविंग these fasciculations in the tongue. This is a child who's having these tremors, fine tremors, which are the polymyomyoclonus. So ये टंग फैसिकुलेशंस है और ये ट्रेमर है जो polymyomyoclonus है. उससे हम सस्पेक्ट कर सकते हैं जब ये बच्चा हमारे पास आता है. But if you have weakness of the extraocular muscles, the diaphragm and the myocardial with the marked facial weakness, some sensory disturbances, CNS involvement, and if the CPK is more than 10 times upper limit of normal, जो CPK है can be enlarged, can be raised in some patients of SMA, but they cannot be more than 10 times normal. And if they have any other suspicion, so we have to rule out, because अगर कोई एक्स्ट्रा वीकनेस हो रही है आंखों के मसल्स की या कोई भी और CNS इन्वॉल्वमेंट हो रही है या CPK ज़्यादा हाई आ रहा है, तो it becomes an exclusion criteria. So when you have features suspective of SMA, we like to do an MLPA. Earlier we were doing a quantitative PCR, which should be avoided if you can, because in that you get only the SMN1. For the SMN2, it's better to have an MLPA. Then you see the SMN1 and SMN2 copies, and depending on that, you are able to diagnose if it's SMA or not. But if there is any doubt, then we look for the clinical profile again and look for atypical features, because when you're doing the SMN copy, if it's 0 copy, it's confirmed. But if you're having 1 or 2 copies of SMN1, then you look for the clinical features, the atypical profile, like try to do a CK, you may do an EMG, RNST to see what all they are. But if you still have a strong possibility of SMA, we like to do an SMN targeted sequencing. And if we are not thinking SMA, then we go ahead for doing a whole exome sequencing. So we do an MLPA diagnosis is clear, it's fine. If it's not clear, we relook at it. And then if it's a strong suspicion of SMA, you do an SMN1 targeting sequencing. And if SMA is unlikely, whole exome. तो SMA जब हमने सस्पेक्ट किया तो MLPA करना बेटर रहता है. उसके बाद SMN की कॉपी के हिसाब से हम डिसाइड करते हैं कि डायग्नोसिस क्लियर है कि हमारे को SMN टारगेटेड सीक्वेंसिंग करना है या होल एक्सोम करना है. अगर SMN लग रहा है तो SMN टारगेटेड सीक्वेंसिंग लगना है, या लग रहा है कि SMA नहीं कुछ और कारण हो सकता है, देन लाइक टू डू होल एक्सोम सीक्वेंस. सो जो हम SMA के टाइप्स की बात हो रही थी उसमें आपको 1 2 3 लिखा था, उसमें 2 और टाइप्स हैव टू बी एडेड देयर. SMA जनरली क्लासिफिकेशन नाउ इज SMA टाइप 0 which is prenatal, and they are average age of death is first few weeks, and 1 2 3 I mentioned about the age of onset, and 4 has adolescent and adult. Basically SMA types can be because of the age of onset कब हुआ. तो 0 वाला प्रीनेटल है वो प्रेगनेंसी के दौरान से ही होता है. उसका 4N में एडोलेसेंट और एडल्ट ऑनसेट. Basically जो हमारे को what we need for management is functionality is more important. So you can be non-sitters, sitters or walkers, because the multidisciplinary care is guided based on non-sitters, sitters and walkers. तो non-sitters generally SMA1 होंगे, sitters होंगे SMA2 या SMA3 जो नहीं चल पा रहे हैं, या walkers will be SMA3 और SMA4. So basically functional classification of non-sitter जो बैठ नहीं पा रहा है, जो बैठ पा रहा है और जो चल पा रहा है is important to understand, क्योंकि हमारे को उसके हिसाब से ही उसका मल्टीडिसिप्लिनरी केयर होगा, उसका ऑर्थोपेडिक सपोर्ट होगा, और क्या क्या प्रॉब्लम्स आ सकती हैं वो विच विल बी डिपेंडेंट ऑन उनका फंक्शनल लेवल क्या है. और DMD की जो मैंने आपको बताया था कि बहुत बड़ी जीन है, 79 एक्सॉन्स है. इसमें क्या है कि जो जेनेटिक मैकेनिज्म होता है उसके अंदर क्या प्रॉब्लम होता है. तो ये वाला जो नॉर्मल है उसमें तो सारे 79 एक्सॉन का ठीक है, लेकिन जो DMD वाला होता है उसके अंदर व्हाट हैपन कि उसके अंदर कोई डिलीशन हो गया है. उसके बाद क्या है, दोनों साइड में आगे वो नहीं अपोजिंग एंड्स आप देखो अलग हैं, तो इसलिए वो आगे उसका प्रोटीन बनेगा ही नहीं. तो इसलिए उसमें वीकनेस ज़्यादा होते हैं. और वो एक नॉनसेंस म्यूटेशन कुछ होता है जिसकी वजह से वो आगे बढ़ता ही नहीं है. और बेकर्स वाला जो होता है इसमें डिलीशन है, लेकिन जो उसके साइड के एंड है वो अपोजिंग है, तो थोड़ी सी फंक्शनल डिस्ट्रोफिन बनते हैं. सो बेसिकली वी कैन सी इन द नॉर्मल यू हैव अ नॉर्मल डिस्ट्रोफिन प्रोटीन इन द डूशीन्स बिकॉज ऑफ द शिफ्टिंग ऑफ म्यूटेशंस, एंड देन देर इज नो नॉर्मल अपोजिंग एंड. सो you will not get because of incorporation of amino acids after deletion, there may be finally a premature truncation of the formation of the protein. And in the nonsense mutation there will be anyway, there will be a premature truncation. And Becker's, what happens is after the deletion also the translation continues, because there will be a partially functional protein because you still have the opposing ends. So this is just grossly to understand, because that's how your manifestations are there. And before we end the first part, just want to remember that there are some primary events and secondary events in DMD, and it is a dystrophin deficiency, and then there is an ongoing oxidative radical damage and inflammation. So basically you may have abnormal permeability of calcium and increase in the intracellular calcium, and then you may have ultimately inflammation and apoptosis. Because of oxidative radical damage and inflammation, you may have abnormal fibrosis and regeneration. So because of these, you can act on any of these areas so as to give benefit to the child. तो DMD में ये इंपॉर्टेंट है याद रखना कि डिस्ट्रोफिन की कमी है, लेकिन डिस्ट्रोफिन की कमी है साथ में कुछ ऑक्सीडेटिव रेडिकल्स का डैमेज है और कुछ इन्फ्लामेशन है जिसकी वजह से डैमेज चलता जा रहा है. तो कोई भी जो प्रॉब्लम्स हैं ये सारी, उन सारी प्रॉब्लम्स में आप इफेक्ट कर सकते हैं. आप वहाँ पे हम कोई भी दवाई के ऊपर वर्क कर सकते हैं जिससे बच्चे का फंक्शनल आउटकम इम्प्रूव होगा. सो ये इंपॉर्टेंट है टू अंडरस्टैंड द सेकेंड पार्ट. तो पॉइंट्स टू रिमेंबर इज वन टू सस्पेक्ट, जो हम we have been able to understand, and the early diagnosis, keeping in mind that ultimately we need to have an holistic multidisciplinary approach. We will be talking in the second part, and optimizing the treatment of patients, and genetic counseling and prenatal diagnosis has to be done, and we have to think about the neurotherapeutic options. And this is a multidisciplinary approach which we will be talking. It's very important. तो हमारे को उनको सस्पेक्ट जल्दी करना है, डायग्नोसिस जल्दी करना है, होलिस्टिक मैनेजमेंट करना है, और उसके बाद वो होलिस्टिक मैनेजमेंट के आगे हम सेकेंड पार्ट में बात करेंगे। लेकिन मल्टीडिसिप्लिनरी अप्रोच को भूलना नहीं है। और पेरेंट इन्फॉर्मेशन के लिए बुकलेट्स हैं, हमने DMD SMA के लिए बनाया है, जो हमारी वेबसाइट www.pedneuroaims.org में है, www.pedneuroaims.org, parents corner. There is a parents corner there, and that you have lot of parent information material, out of which DMD and SMA you have in English and Hindi. So basically we have to be very hopeful, and we are very grateful to all the parents and families who have always reposed their faith in us. I think I come to the end of the first part of the thing, and we can open for discussion, and anybody, uh, yeah, you can raise your hand, and Dr. Kakuli will unmute you.
Dhanyavad, Dr. Shefali. I think everybody has gained a lot from this presentation, which today Dr. Shefali has pointed about the onset and the other remedies which can be followed for the SMA and DMD patient. Now we'll open the session for the poll. You'll have 10 minutes. Kindly go through the poll questions quickly, and इसके बाद हम लोग क्वेश्चन आंसर्स लेंगे, जो कि डॉक्टर शेफाली एंड काफ़ी सारे हमारे पैनलिस्ट जिन्होंने ज्वाइन किया है, वो लोग भी क्वेश्चंस के आंसर्स के लिए we'll reach to them also, so that we can have all the answers for your queries. केवल 10 मिनट के लिए होगा. One can take a bio break also in between and have the response to the poll questions.
You've shared the poll link.
Multiple choice questions hai. Kindly go through each and every questions. I think all the information which Dr. Shefali has covered in her presentation will be very helpful in going through. These are very simple and very easy questions for you, so that we also understand how much we are able to reach you people with these presentations, with the support of global genes, allies in rare disease. Good morning, everyone. We have ended the polls. We have got the responses from everyone, and we can see many of the questions which are there in the chat. I would request Dr. Shifali to take the questions, and also the experts who have joined our talk can kindly take the questions. Dr. Shifali, to you.
Dr. Nalini, would you like to say something, please?
Good morning, ma'am. Good morning, everyone. It was a very nice talk, ma'am. It's actually brushing up our basics, and the basics are actually the cornerstones of approach of any disease. And it was very nicely and simply said approaches, and easy for us to remember also. And anyway, for forthcoming sessions, we'll be talking about treatment and novel therapies. Thank you so much, ma'am. I just want to ask one question because sweat glands are actually any in skin. The glands, sweat glands or sebaceous glands are supplied innervated with the autonomic nervous system, and these muscles are actually usually of smooth muscle type. And how does a skin biopsy helpful in a Duchenne muscular dystrophy, which is a skeletal muscle dystrophin involvement?
You have erector pylori muscle there. I had shown you 1 minute. I'll show again. 1 sec.
Yes.
Let me just show. So 1 minute. So we stained. We've done the studies in which we have stained. So I'm just going back 1 sec. Yeah, see. So this has been done. Na? So this is the erector pylori muscle which is there, and that is why the staining has been done. This is for dystrophin patient. This was negative, na? Dystrophin is negative in this patient. So you can do it, and that's why we have done it for we have done it for CMD and all. We have been trying to do. First we did for dystrophinopathies, then we did for other. So that is why this with focus on the rector pylori. What we were and what we were doing was we were doing it because we were comparing with muscle biopsy, na. So we were basically doing. So we were basically doing, like to understand whether we can stain and all, and whether we can replace them. So that we were basically doing from the muscle biopsy site when we were suturing the skin. From that side, we were taking out because we did not want to punch again separately, right? So that's how when we did in the studies. So now also when we are doing it, we are doing there, and when we doing it in the research mode, both of them. But ultimately, when we can do by punch biopsies, skin biopsies. So that is how it is. And there are some papers for it which you can actually see and put it. There'll be papers are there. Okay. Thanks.
Thank you so much.
You're from which place, Nalini?
Ma'am, I'm from AIIMS Bilaspur, ma'am. Himachal Pradesh.
Okay. Mr. Sunil wants to say something.
Madam, at first, thanks for your great and nice presentation. And then I am Sunil Kumar from Trivandrum, Kerala. I am my son. I am the father of a 17 years old DMD boy. Hello, madam. Can you hear me, ma'am?
Yeah, we can hear you.
My question is now, any change in management for the adult DMD and the child DMD? Because my son is now 17. And then other question, can I continue with my pediatric neurologist or I shifted to the adult neurologist?
We'll be replying this in the second part. This is a part of my presentation in the second part. That the definitive treatments which have come up are the same, but for holistic care will depend on the age and the problems the child has. So that will be talking and about the transitional care and palliative care, two aspects of transitioning from the pediatric neurologist to an adult neurologist, and talking about palliative care as the case may be. In the advanced situation, I'll be talking in the next part of it.
Madam, some more questions.
Yeah.
Hello?
Yeah, please.
Madam, other question.
Yeah.
My son is under the steroid since the last 12 years.
Yeah.
But fortunately, till this time, he didn't show any side effect. Much side effect. But can I test the poverty? I evaluate all factors, but Can I test the puberty? Puberty?
Test the what?
Puberty.
No,
Puberty.
that's yeah. He must. What is his age, na? So you have to do a whole holistic evaluation. So you should be showing in when you go to the pediatric neurologist, you can please ask him, and then if required, they can show to the endocrinology. And one thing is there when we'll be talking about it subsequently, we will just talk about it. Then when the child becomes non-ambulatory and all, then also steroids have to be given, but the dosage have to be reduced. Doses have to be reduced in that situation.
And now he is taking the 24. His weight is 50 kg.
Okay, and thank you, Dr. Mona. Dr. Mona, you had written something in the.
Yes, I think your questions are answered now. A few of the questions which are there in yes, Mona was having few questions. I'll ask Dr. Shefali to respond the questions. Mona, can you please have your questions for Dr. Shefali?
Dr. Mona.
Yeah, I think Madam has answered them in the chat.
Yeah. I wanted it because I thought I am pointed out because many times people may not read. So Mona, what happens is we have some patients who have DMD as well as autism. And as I mentioned to you that even in, I had shown one case example that you may have a normal MLPA and you still may have DMD. So in that case, you should do a whole exam. So in your case, which you had direct messaged me, in that situation also, if your MLP is negative and the child has calf hypertrophy, I think you should do a whole exome. But you may understand, I mean, everybody should understand that you may have two coexisting things, and DMD has been shown to be associated with, autism spectrum disorder as well. So because there is no other difference in their management except that they have two conditions. So their coping thing and their understanding how much is the cognition of the child, how much he understands, because cognition becomes very important in the child with autism also to understand whether his understanding is DMD. So we have had couple of children that's why I pointed out. Thank you, Dr. Mona.
Ma'am, we have few more questions, ma'am, before we go for the next session. This is a question from Mr. Sanjeev Verma. He is asking about, is there any updates on latest gene therapy trials? And he has a 3-year-old child who is suffering from SMA2 and SMN2 copy number 3.
I think I'll be answering in the next one, but yes, we do have a trial which is going to start from 2 years to 18 years. Children with the SMA on, they'll be having intrathecal Zolgensma. So that trial will be starting soon. So once those the approvals are on.
Hope Mr. Sanjeev, your questions are answered. We have one more question where we can see similar kind of question where they are asking for Mr. VC. He is asking us that is there any clinical trial going on for DMD exon 39 nonsense mutation? And also he would like to know how to register with AIIMS to participate for future trials.
Basically, nonsense mutation trial is over. For the nonsense mutation, you have Atalurin, for which the trial enrollment got over in September 2020, and the follow-up of patients is also over now, and they are now getting on humanitarian basis. They are continuing the compassionate giving them drugs. The trials are over for Atalurin, and but if anything comes up in the big area, we have a website www.pedneuroaims.org where we had actually put the ongoing trials, but that has not been updated recently. We will be updating, and I think, and I'll make it sure that we update all them 3 monthly so that everybody gets access from there itself. But you can contact us also through our emails which are there, but we will ensure that the website gets updated, the ongoing trials besides the AIIMS website which is there, but then in that it doesn't get that frequently upgraded. So we will ensure that in that www.pedneuroaims.org, which is a division website, we will upgrade and put the ongoing trials periodically. I think monthly or so we'll update something, we'll do, so that anybody sitting anywhere should be able to. But if anybody has any doubt, they can reach out to us on the emails.
Thank you, Dr. Shefali, for answering all the questions.
Madam, Madam, one more question.
Yes.
I heard that the DMD affected brain. How we know that it is affected by brain? And I think that there is some patient shows some behavior issues. So can you tell me about
Yeah, I
this?
did mention to you, if you remember, I had shown you the slide in which I had mentioned that around 30% of them may have intellectual impairment as well. And you have lots of them who may have behavioral problems, which may be, in the form of ADHD. 23%, 41% were also having other behavioral problems, and feeling low was 51%. So so we have to proactively look for all these. And that is why when we are looking at the holistic management, which we'll be talking in the second part of it, that we need to focus on all these aspects, because we have to ensure that each child is looked at with humanistic attitude and has been able to have a most fulfilling life and reach the maximum potential functionally and intellectually, whatever is possible for that individual's capacity.
Ma'am, I have one question. So you mentioned that for nonsense mutation trials are over, and on humanitarian ground, you guys are
It's going
providing.
on. It's going on for the trial patients only. The humanitarian one is only those who are part of the trial. Now they are being given. Right now, there is no humanitarian access going on for anything in DMD. There are some humanitarian access going in SMA. I will be mentioning about them. So this humanitarian access was only for those who are part of the trial, because it was not ethical. In the initial part of the trial for 72 weeks, half of them got the medication, half of them got the placebo, right? Then after that, then everybody got the medication, right, and the open label. Then after that also, now everybody is now they are continuing. Everybody has been offered, so they are being given as of now. Everybody is taking. So, but that is of those who participated in the trial as a part of a moral responsibility from the sponsors of continuing their care, because they participated in the trial.
So, ma'am, are there any chances that kids who were not part of this trial would get that medicine?
No, they will not get from that because that humanitarian access is a continuation of their trial patients globally. So they will not get. So if anything comes up, we will put. So even our humanitarian access thing, I think for reach, I think we will be putting all those updated. There is a portion which is ongoing trials, but we have not updated it for some time. It's it's maybe because of overwork, but I think that's a moral responsibility, and I think. We will ensure that it is done during the course of these webinars itself, and we take it periodically. We'll put a column for the humanitarian access as well, so that that which all humanitarian access is available. I'll be talking about whatever is available in the second part.
Okay, thank you.
Thank you, Dr. Shifali, and thank you all the participants who had been having their own questions. I think hopefully everybody has got.
Can
their
you
answer.
see Kakuli in the YouTube if there is any question that we can just check? Yeah.
And meanwhile, I think we are running short of time. We'll start with the second presentation also, and I'll definitely look into the other questions which are posted online, because we are having a wide coverage through our YouTube and also through the Facebook.
Thank you. So, if anybody, we will start off with the second part.
We are coming to the next session, which Dr. Shefali would present about the multidisciplinary management of neuromuscular disorder. She would cover SMA and DMD both. So we'll again have questions invited post presentations. Kindly go through the presentations carefully so that you people can gain through the presentation related to SMA and DMD. Over to Dr. Shifali.
Yeah, thanks, Dr. Kakuli. So basically, multidisciplinary management, and why I have put the word multidisciplinary before this, because we have to keep in mind how to see holistically and do all for these children. So multidisciplinary management. So dystrophinopathies we have diagnosed. We have already diagnosed. After diagnosis, we are going to see the we have to see the functional status of the child by various time functional capacity and all the muscle power testing, and then also see for the heart and the respiration and the IQ or DQ, right? And then whether the child is ambulatory, non-ambulatory becomes important. Then we have two aspects of the care. One aspect of the care is a medical management and the other is supportive care. The medical management standard of care is steroids, and there are some new approved drugs. But this is the most important slide because it's the most neglected part is multidisciplinary approach to management, which includes looking at musculoskeletal system, growth and nutrition, pulmonary, cardiac, other systemic evaluation, psychological counseling, pharmacological management, physiotherapy, occupational therapy, special education, and any supportive devices in all we'll have to think of. तो मल्टीडिसिप्लिनरी अप्रोच बहुत इंपॉर्टेंट है. वी हैव सीन कि पिछले स्लाइड में कि जब बच्चे को डायग्नोज कंफर्म किया है उसके बाद उसका क्या फंक्शनल कैपेसिटी है वो देखना है, चल पा रहा है नहीं चल पा रहा है. मेडिकल मैनेजमेंट जिसमें हमने स्टीरॉयड स्टैंडर्ड ऑफ केयर देना ही है और न्यू ड्रग्स जहाँ पे है उनके बारे में बात करेंगे. एंड सपोर्टिव केयर, एंड सपोर्टिव केयर के अंदर जो है ग्रोथ एंड न्यूट्रिशन, हार्ट का, लंग्स का, बाकी सिस्टम्स का, जैसे वो बता रहे हैं यू हैव टू सी फॉर फॉर ऑल द सिस्टम्स, एंडोक्राइन सिस्टम एंड एवरीथिंग. साइकोलॉजिकल काउंसलिंग बहुत इंपॉर्टेंट है. फॉर ड्रग थेरेपी जो है ये जो ड्रग्स के बारे में, फिर फिजियोथेरेपी, ऑक्यूपेशन थेरेपी, स्पेशल एजुकेशन, प्रोवाइडिंग wheelchairs or any other orthoses or providing any respiratory support devices, ये सारा चीज़ों का बहुत important रहता है. So basically there are guidelines which have been published in Lancet Neurology which tells which are about the holistic management. We in India are also adapting from these and will be coming out. I'm coordinating a committee in which we are making guidelines for treatment of DMD and SMA, guidelines for the government of India, and also I'm co-chair for another similar committee for ICMR. So in that we are in the process of adapting these guidelines according to our situation. तो ये बेसिकली मल्टीडिसिप्लिनरी जो सपोर्ट है जिसके अंदर सारा एस्पेक्ट देखना है वो उसकी गाइडलाइंस पब्लिश्ड हैं. हम उनको इंडियन वर्जन में अडाप्ट कर रहे हैं. एक कमेटी को मैं कोऑर्डिनेट कर रही हूँ जिसके अंदर हम बना रहे हैं गाइडलाइंस गवर्नमेंट ऑफ इंडिया के लिए. तो उसके अंदर भी सारा ये होलिस्टिक अप्रोच का बारे में अपना कैसे हमारे इंडिया में कैसे अडाप्ट कर सकते हैं, उसको कैसे करना है वो हम देख रहे हैं. Basically, the pharmacological agents are either they are disease modifying or symptomatic. You remember the slide I showed you? There was that dystrophin deficiency was there, and those free radical and all damage and inflammation and all was there. So you can act on various things. Whether you're acting on the dystrophin thing, which is the disease modifying, which is the stop codon read through exon skipping agents, utropin modulators, which we're talking about, or whether it's symptomatic, which is causing with all the things which I showed you when it's going to prevent muscle damage and accelerating muscle growth. But still the current standard of care is steroid. It's to be remembered. तो जो दवाइयाँ हैं हम दे सकते हैं वो तो या तो जो बेसिकली जो डिस्ट्रोफिन को इफेक्ट कर रही हैं जो कि डिफरेंट एजेंट्स हैं जो इस साइड पे लिखे हैं जिसके बारे में हम बात करेंगे बाद में, या सिम्टोमेटिक हैं जो ऑनगोइंग मसल डैमेज हो रहा है जो मैंने आपको स्लाइड में दिखाया था उसको कैसे प्रिवेंट करें और रिपेयर को कैसे इम्प्रूव करें. लेकिन करंट स्टैंडर्ड ऑफ केयर इज स्टिल स्टीरॉइड्स एंड दे हैव टू बी गिवन. कई बार कई लोगों को स्टेरॉइड के नाम से टेंशन होता है, उनका साइड इफेक्ट का सोचते हैं और उनको ये भी नहीं समझ आता कि वो ऐसे ही स्टेरॉइड दे रहे हैं करके. आगे स्लाइड्स में पता चलेगा कि डेफिनेटिव रीज़न है जिसकी वजह से स्टेरॉइड देना है और स्टेरॉइड हैज़ टू बी गिवन. और जो नया ट्रीटमेंट अगर देना है तो वो ऑलरेडी वो बच्चों को स्टेरॉइड पे होना पड़ेगा, वो एड ऑन है, एडिशनल है. सो we have to be as professionals also think that steroid is the standard of care and it has a definitive mechanism of action, and then we need to ensure that we are giving steroids and they are required for patients who will be actually ultimately be giving any definitive therapies. So medical management जो है, we actually like to do chest X-ray and MAN2 for these children because to rule out tuberculosis, we like to immunize the child with varicella, pneumococcal vaccines and influenza vaccines, and we are given that, and we give prednisolons, and prednisolon we give point.
Recording in progress.
We forgot to. पुराने वाले में YouTube. Okay. Okay, sorry. So we started, so we have immunized the child with varicella, pneumococcal and influenza vaccines. We start with prednisolone 0.75 milligram per kg per day and for ambulatory patients, and when they become non-ambulatory, you reduce the dose to 0.4 to 0.5 milligram per kg per day. For Deflezicort, the dose is 0.9 mg per kg per day. So you have to understand that it has to be given and the dose may be reduced when the child becomes non-ambulatory, but they have to be given whether prednisolone or you're giving Deflezicort. तो हमारे को वी हैव क्या करना है कि एक्सरे और मैंटू करा के ट्यूबरक्लोसिस को रूल आउट करके वायरसेला न्यूमोकॉकल इन्फ्लुएंजा वैक्सीन करना है, जिससे हमारे जो बच्चों को चेस्ट इन्फेक्शन वगैरह ना हो. प्रेडिसलॉन देना है और अगर वो बच्चे जब बाद में नॉन एम्बुलेटरी हो जाते हैं, चल नहीं पाते हैं, तो उनका डोज कम कर देते हैं पर चलाते हैं, क्योंकि आपको पहले भी बताया था कि जो मसल्स थे बाकी मसल्स को भी इफेक्ट करता है, ताकि नॉट ओनली हाथ पैर के ना बाकी मसल्स कभी था हमने डिस्कस किया था कि वैस्कुलर मसल्स जो है उसका लंग्स का, गैस्ट्रोइंटेस्टाइनल का, ब्लैडर का, सभी का, हार्ट का, सब में इफेक्ट होता है, तो इसलिए देना बाद में ही पड़ता है. ना अदर सब्स्टिट्यूट डिफ्लेक्सिकॉर्ड है. तो ये सारा द मैकेनिज्म ऑफ एक्शन फॉर स्टेरॉइड एक्शन इज टू इनिबिट द मसल प्रोटियोलिसिस, स्टेबलाइज द मसल फाइबर मेम्ब्रेन्स, increase the myogenic repair and reduce cytosolic calcium concentrations and differentiate the regulation of genes in muscle fibers and suppression of humoral and cellular immune responses. The idea to list is that there is a evidence and there is a mechanism by which it acts. It is not a placebo. तो स्टेरॉइड्स का रोल है, उसका जो कारण है जो लिखे हुए हैं वो सारे कारण हैं जिसकी वजह से वो फायदा होता है, ऐसे ही नहीं है जो दिया जाता है तो हमें देना है. Then you have to do a respiratory muscle training in patients with Duchenne muscle dystrophy, and in that it was in a Cochrane review, it has been shown that it improves lung capacity and respiratory muscle strength in some neuromuscular diseases. And clinical heterogeneity between and the small number of participants and risk of biopsy वगैरह was there, so we have to do more studies. But यह है कि respiratory muscle training जो है बच्चों में बहुत ज़रूरी है, मसल की रेस्पिरेटरी की मसल की स्ट्रेंथ इंप्रूव करने के लिए और उसकी लंग कैपेसिटी के लिए. कार्डियक इवैल्यूएशन इज रिक्वायर्ड and less than 10 years children you do it once in every 2 years, and more than 10 years you do it annually. And we consider starting ACE we can give ACE inhibitors and all are given. Some medications are given if you are having any problems which are coming up. Then तो हार्ट वाला इवैल्यूएशन लेस देन 2 years 10 years में 2 साल में एक बार है और मोर देन 10 years में एनुअली है. कुछ दवाइयों का रोल है. उसके बाद है कि बोन हेल्थ इवैल्यूएशन इम्पॉर्टेंट is very important, and serum calcium and phosphate levels, if they are abnormal then we do vitamin D and they're doing biannually, and DEXA can be done annually. And it's important to understand and see the child's growth velocity and look for spine scoliosis and all whether we require. And as the question was asked, endocrine evaluation and annual SMR staging has to be done. तो बोन हेल्थ को देखना है, बहुत ज़रूरी है. कैल्शियम, फॉस्फेट, विटामिन डी, डेक्सा, एक्सरे कराना पड़ेगा अगर स्कोलियोसिस हो गया है, एंड अगर उनका जो एंडोक्राइन पार्ट में एनुअल सेक्सुअल मैच्योरिटी स्क्रीनिंग देखना है. Whether corticosteroids does earlier treatment matter? This has been shown that boys who were started treatment before 5 years of age showed a trend towards slower functional decline. अगर हम 5 साल से पहले बच्चों को शुरू किया था तो बाद में उनका जो जिस रेट से उनकी प्रॉब्लम बढ़ती है वो थोड़ी स्लो हुई थी. There is no significant difference between the two groups of 0.75 versus 1.5 in regard to strength and functional benefit at 6 months. But the weight gain was higher, in the groups with which you give higher prednisolone. तो अगर जो डोज है हम 0.75 mg पर kg देते हैं, 1.5 mg पर kg देने से कोई एडिशनल स्ट्रेंथ या फंक्शनल बेनिफिट नहीं था, बट कि उसके अंदर वेट गेन बढ़ गया. अब डिफ्लेक्सिकॉर्ड इज अ न्यू ड्रग, लिटिल बिट newer compared to Isolone, but it is caused got a similar efficacy as the daily dose of 0.9 milligram per kg, and it appears to be a alternative to prednisolone, preserving its benefit but fewer side effects. Because the side effects which were there, they were less amount of pushing point thing, the increased appetite and all increased hair were also lesser than in steroids. डिफ्लेक्सिकॉर्ड दे सकते हैं पर उसमें अल्टरनेटिव है, थोड़े से साइड इफेक्ट कम होते हैं. but there is no evidence, there is no definite conclusion that it doesn't appear clear whether it favors deflazacort or prednisolone. So जो अभी तक कोई जो clear नहीं है कि कौन सा better है. Regarding intermittent versus daily regimen of prednisolone, we had done a study in 5 to 10 years children, a randomized open label trial. And in that we found that intermittent prednisolone therapy, which we were giving for 10 days every month, was not inferior to daily therapy in improving muscle strength. So basically, agar we were giving for 10 days and not giving for 20 days, still there was not inferior in improving the muscle strength. दिस वाज वन स्टडी विच वी हैड डन. तो हमने एक स्टडी में दिखाया कि अगर 10 दिन दवाई देते हैं और 20 दिन ऑफ देते हैं, फिर भी जो मसल की स्ट्रेंथ को इम्प्रूव करना कम नहीं होता है अगर हम ऑफ करते हैं. बट देयर वाज अ लॉन्ग टर्म बेनिफिट्स विच हैव बीन स्टडीड इन अनदर स्टडी एंड एडवर्स इफेक्ट्स ऑफ इंटरमिटेंट वर्सेस डेली. In that they showed that in the median loss of ambulation, it was 12 years in intermittent and it was more than 14 years in daily. So those who intermittent were declining faster, because our study was only a short term study, so we could not see this part. And moderate to severe side effects were higher in the continuous than in the intermittent therapy, and that was stunted growth and increased weight, the BMI. तो बेसिकली हमारा जो स्टडी था वो शॉर्ट टर्म था. तो लेकिन जो लॉन्ग टर्म स्टडी है जो किया है उसमें दिखाया कि जो बच्चों को इंटरमिटेंट देते हैं वो थोड़ा कम चलते हैं. वो 12 साल में नॉन एम्बुलेटरी हो गए थे, जबकि दूसरे वाले जो डेली दे रहे थे तो मोर देन 14 ईयर्स दे रहे थे. And side effects in the form of stunted growth or जो increased BMI obviously was more in the high group. So you have to obviously weigh both of them and give. So whether corticosteroids have a effect on the cardiac function. So you are doing at least once every 2 years, as I mentioned, until 10 years, and after that annual assessments are done. So that is important. हमें पता है कि हमारे को less than 10 years में हर 2 साल में और उसके बाद annual करना है. And this was a study in which they had shown basically that steroid treatment caused a 85% reduction in all-cause mortality and fewer heart failure related deaths. Steroid use was associated with 86% lower rate of new onset cardiomyopathy. And annual rates of decline in LV injection fraction and fractional shortening was less pronounced in steroid treated patients. तो बेसिकली स्टेरॉयड ट्रीटमेंट से 85% बच्चों में रिडक्शन हुआ था कोई भी कारण से मोर्टालिटी होने का एंड फ्यूअर हार्ट फेलियर रिलेटेड डेथ्स मतलब. एंड तो 86% कम हुआ था न्यू ऑनसेट हार्ट रिलेटेड मसल प्रॉब्लम. और जो एनुअल जो आपका लेफ्ट वेंट्रिकुलर इजेक्शन होता है उसकी कॉन्ट्रैक्टिकल ये फंक्शन है और फ्रैक्शनल शॉर्टनिंग है वो आहिस्ता आहिस्ता कम होती है. लेकिन जो स्टेरॉयड वाले को बच्चों को दिया था उनकी जो गिरावट है वो कम हुई थी. दैट मीन्स देयर इज अ बेनिफिट. हमें स्टेरॉयड देने से हार्ट के मसल में बेनिफिट है. या दूसरा है बेकर्स में दिया जाए कि ना दिया जाए. तो ये सजेस्टेड है कि कुछ पेशेंट्स में जो है उनके अंदर रिस्पॉन्स आता है कॉर्टिकोस्टेरॉइड्स का, तो सारे पेशेंट्स को केयरफुल ट्रायल देना चाहिए. स्टेरॉइड से अगर बेनिफिट हो रहा है तो देन इट शुड बी कंटिन्यूड. सो फॉर बेकर्स देयर हैज बीन शोन दैट स्मॉल परसेंटेज में हैव अ ड्रामेटिक एंड सस्टेन्ड रिस्पॉन्स टू स्टेरॉइड्स एंड they may be tried. Prednisolone trial may be given. This is in response to another question which was there because it's an important thing, because people with DMD will need education and support with transitions throughout the lifespan. So you need to help them navigate transition from adolescence to adult life. This was in response also to another question. So it is very important that we make a summary of the child and hand over the patient personally to the adult neurologist for the care. तो ये इम्पॉर्टेंट है क्योंकि बच्चे बड़े होकर एडोलेसेंट बन रहे हैं, टीनेजर बनते हैं, उसके बाद उनके अंदर एडल्ट्स में जा रहे हैं. तो बिल्कुल प्रॉपरली हमें पीडियाट्रिक न्यूरोलॉजिस्ट को पूरा बच्चे को होलिस्टिकली देख के उनको फॉर्मल वे में उनको हमारे को देना है, हैंड ओवर करना है टू द एडल्ट न्यूरोलॉजिस्ट. नाउ कमिंग टू the treatment which is affecting on the dystrophin gene per se, the actual one, right? Definitive one. They are 4 kinds: exon skipping, stop codon read through, gene therapy, genome editing. तो ये वाली जो सारी थेरेपीज हैं वो डिस्ट्रोफिन के जो है उसको रिप्लेस करते हैं या रिस्टोर करते हैं. FDA approved drugs currently are Atalirin was approved by European Commission in 2014 for more than 5 years age ambulatory DMD patients, but FDA approval is lacking. And the study which we are talking about, which is going on by PTC globally, in which India is a part, and we have multiple sites, and AIIMS was also a part. In that, after that, the FDA will give approval pending on these results. Eteplirsen is for 51 exon skipping. Deflazacort is for 20, was also there, which was came later and was also approved in 2017. So 2014 that Atalirin happened, then Exondys 5116, then February 17 you had Deflazacort. Then you got approval for Golodarsen for 53 in 2019, then Itolorsen for August 2020, and then Casimersen for 45 in February 2021. So all these things are there, but you should understand all these drugs have specific indications which we will be talking about. तो अभी FDA approved drugs की बात है तो 51 skipping 45 और 53 के लिए है, और अभी Deflazacort भी approved है, और जो Atalirin है nonsense mutation वाला वो अभी यूरोपियन कमीशन में approved है. Atalirin, which we're talking about, is for a nonsense mutation, and it is approved in South Korea, Israel, and European Union, and it is given orally. And there are oral suspensions which are there, and oral medication which is there, and not very many side effects. तो ये वाला ऑलरेडी साउथ कोरिया, इसराइल और यूरोप में अप्रूव्ड है, अभी बाकी और जगह नहीं है. ट्रायल जो हमारा अभी ख़त्म हो रहा था बता रहे हैं, और ये ओरली देते हैं दवाई, इसके कुछ ज़्यादा सिग्निफिकेंट साइड इफ़ेक्ट्स नहीं देखे गए हैं. इसके अंदर क्या होता है, we'll be seeing. So as I mentioned to you, because of the nonsense mutations, you have a premature termination of the translation, right? But now with the Atalirin, it is allowing for a read-through product, and it is it is suppressing the nonsense suppression. तो इसमें क्या है कि हमने देखा था कि फुल स्टॉप की तरह स्टॉप कोडन आया तो आगे बनना बंद हो जाता है प्रोटीन, लेकिन इसके अंदर जो है कि वो उसको रीड थ्रू हो जाता है, बाईपास कर लेता है. Atalirin has been shown in patients to be improve. It's a better significant effect has been shown in those children who are able to anyway walk for 300 meters or more in 6 minutes. तो Atalirin को दिखाया गया है कि it is beneficial to patients who are walking for 6 minutes में more than 300 meters. And it is also shown that it slows the progression of the disease over 48 weeks. And again, it was most evident for those who could walk more than 300 meters. So obviously, तो इसमें यह है कि जो progression को थोड़ा कम करता है, and again 6-minute walk test जो more than 300 meters. मतलब है जब हम ट्रीटमेंट चालू करें तो ज़्यादा जो ऑलरेडी चलना बंद कर दिए उसमें कितना रिस्पॉन्स होगा वो नहीं मालूम. जो बच्चा चल रहा है 6-minute walk test 300 to 400 उसमें बेनिफिट बताया. Coming to Eteplirsen, that was for the nonsense mutation. Now we are coming on the antisense oligonucleotides, which are for exon skipping. So what happens is that suppose here these exons are missed, right? They're not there. So what it is doing is it is skipping that area. This ASO, crudely speaking, it is skipping. Can you just remove this graphic from the things? Yeah. So can we? So what happens is it bypasses. What happens? It will bypass the. One second. Yeah, sorry, one second, just.
Kindly be there. Will be.
Yeah, one second. I just put some mark. Yeah. I just marked something on the screen, so I realize it can't be seen. ये तो नहीं है. अब आएगा? Okay. Okay.
We are just doing the needful. We'll connect with you. Just be there for some time.
Sorry, I actually marked something on the screen, so I thought that you can't see the screen. Yeah.
We are there with you.
Yeah. So basically, I marked something on the screen by mistake. So I was just saying that certain exons are deleted, right? So exons are deleted here. So with this ASO, antisense oligonucleotide, it is bypassing this Brutally speaking. So basically, these are basically short synthetic strands of DNA analog that hybridizes with this complementary mRNA, resulting in formation of the RNA DNA hybrid. So this helps. So it has been shown this has to be given weekly infusions, and they have been shown to increase the local dystrophin production. बेसिकली क्या है, जो कुछ एक्सॉन्स डिलीटेड हैं वो स्पेसिफिकली है ग्रुप्स होता है, दे आर आइडेंटिफाइड विच ऑफ देम आर एमिनेबल, तो उसके ऊपर ये बाईपास कर लेता है बाय गोइंग एंड बाईपासिंग द थिंग. सो इट हैज़ टू बी गिवन वीकली इन्फ्यूजन, पर बिकॉज सी इट इज़ डूइंग that time, so it has to be given lifelong. Once you stop doing it, then the result will go off. So basically, studies which have shown that it reduces the decline of a 6-minute walk test over 96 weeks. तो जो डिक्लाइन हुआ है उसको थोड़ा स्लो करता है, उसको कम करता है. फिर उसके बाद there is another study on long term ambulatory function in children, and they've seen that eteplirsen treated resulted in attenuation of the decline. तो मतलब जो डिक्लाइन हो रहा है 4 साल के ऊपर वो थोड़ा डिक्लाइन को स्लो करता है. Then another study in which 10 patients, they had remained ambulatory throughout, and they had maintained the cardiac and upper limb function. So basically they had seen non-ambulatory के अंदर भी जो है, those patients who were non-ambulatory, in that also they saw that the cardiac and upper limb functions were benefited. That was also seen in the non-ambulatory, मतलब जो नहीं चल पा रहे हैं उनका हार्ट का और अपर लिम्ब का फंक्शन इंप्रूव हुआ. There's another study in which they showed that you have the force vital capacity decline that was also reduced in these patients. तो जो लंग का फंक्शन कैपेसिटी जो डिक्लाइन हो रहा है वो भी थोड़ा कम हो जाता है. These are few small studies which have shown. फिर ये जो गोल्डेरार्सिन और वेटलार्सिन, these are for 53, so they are also weekly infusions, and they can also have some side effects, but these weekly infusions will also be continued lifelong, because it's the same way like you had for the 51, so this is also skipping going to be for 53. So it doesn't mean that it is skipping one. There is a group of, it is available what all kind of mutations are going to be amenable. So that is available, and when we see that, we'll be able to say whether it is amenable to this 53 skipping, whether this molecule, whether it goes and sits there and can bypass it, the problem, crudely speaking. तो ये जो 53 वाला भी है वो भी weekly infusion है, and it has been shown that on muscle biopsies was shown that golderarsin showed increased dystrophin production. So they had increased dystrophin production seen on muscle biopsy. तो मसल बायोप्सी में थोड़े जो बच्चों में देखा है कि दे हैव सीन कि उसमें प्रोडक्शन बढ़ जाता है. देन वेटोलर्सिन वाज आल्सो स्टडीड, द अदर ड्रग, उसमें इट हैज बीन शोन that it induced de novo dystrophin production and clinical improvement of the time functional capacity. So उसमें भी दिखाया कि वो डिस्ट्रोफिन का जो प्रोडक्शन है बढ़ रहा है, और थोड़ा सा जो फंक्शनल हम बोलते हैं कितनी देर में उठ रहा है एंड कितना चल पा रहा है, वो सब थोड़ा सा इम्प्रूवमेंट दिखाया गया है. सो कैसिमर्सिन जो है, एज आई टू मेंशन, वाज FDA अप्रूव्ड इन February 2021, and casimersen is well tolerated, and it has been just shown that it is well tolerated and side effects are less. So casimersen जो अभी 45 वाला है उसको अभी बस इतना ही दिखाया कि it is well tolerated. Another category of drugs are eutropin, which is also there, which is a homologue of dystrophin. It's expressed in a reciprocal manner, and eutropin upregulation naturally occurs in dystrophin deficient muscles and can be enhanced through drugs. So eutropin has been a potential to serve as a substitute in dystrophin deficient subject. तो इसके अंदर क्या है, dystrophin के through, उसके मतलब it can be as a substitute for dystrophin deficient individuals में, and if we can have some drugs by which you have eutropin का upregulation, तो इसके ऊपर भी research जारी है. So this is a medication eutropin which increase eutropin in skeletal and cardiac muscle. तो ये जो दवाई है इससे थोड़ा सा स्केलेटल और कार्डियक मसल में यूट्रोपिन प्रोडक्शन इंप्रूव दिखा है. दिस इज अ स्लाइड विच इज फॉलो अप ऑफ द वंस विच आई मेंशन अर्लियर, दैट यू हैव समथिंग अफेक्टिंग द डिस्ट्रोफिन एंड सेकेंडरी चेंजेस. सो यू कैन have effect on all these by how? So something is by absence of dystrophin we have talked about the various ways. Then you can have influx of calcium can be is affected by creatine. You're giving L-arginine for decreasing nitric oxide, decrease AMP activated protein kinase by metformin or heparin. Idebenone is an for anti free radical mass damage and all for inflammation. All these things can be done. And recently there have been studies of vamorolone, which is being used as portrayed as a corticosteroid replacement. तो बेसिकली कहीं पे भी कुछ प्रॉब्लम हो रहा है, सो ज़्यादा डैमेज हो रहे हैं, उनके ऊपर डिफरेंट डिवाइस के ऊपर रिसर्च चल रहा है कि कैसे बच्चों की वीकनेस को इम्प्रूव कर सकते हैं. तो वैमोलोरॉन जो है वो कॉर्टिकोस्टेरॉइड रिप्लेसमेंट के लिए उसका भी स्टडी चल रहा है. दे हैव बीन वेरियस स्टडीज विच हैव बीन इफेक्टिंग एज अ एंटी फाइब्रोटिक, एंटी इन्फ्लेमेटरी, मतलब फाइब्रोसिस जो हो रहा है उसके अगेंस्ट, इन्फ्लेमेशन के अगेंस्ट, इम्प्रूविंग मसल ग्रोथ एंड प्रोटेक्शन, कैल्शियम होमोस्टेसिस. तो मसल की ग्रोथ के लिए, उसको प्रोटेक्ट करने के लिए एक स्टडी चल रहा है. देन दिस इज जीन थेरेपी विथ मेनी स्टडीज आर स्टिल ऑन. As regards gene therapy, Sarepta gene therapy was there, in which 4 boys were enrolled and giving dystrophin, which was called the microdystrophin, and they were encouraging results. Pfizer gene therapy है और एक CRISPR है. CRISPR in which they are doing the genome editing in vivo. तो बेसिकली जीन थेरेपी अभी चल रहा है, पर अभी प्रैक्टिकलिटी में आने में दूर है. दिस इज व्हाट वी शुड रिमेंबर. Stem cell therapy has a lot of hype always, and everything should be, we should be talking about stem cell always. It is important to understand that there is work going on induced pluripotent stem cells, and whether we can do a correction after we can do a correction and genome editing and make a normal iPSCs and then make muscle cells. तो स्टेम सेल के अंदर भी, उसके अंदर भी उनके अंदर कुछ इंड्यूस्ड प्लूरिपोटेंट स्टेम सेल होते हैं, उसके अंदर अगर हम जेनेटिकली उनको करेक्ट करके फिर उसको दें तो देर इज़ अ पोटेंशियल. So regarding stem cells, there have been transplantation of muscle derived cells in 8 boys with DMD. It was done in 2007, and out of 5 patients treated, 4 had shown some increased benefit coming on the muscle biopsy. That's about it. And there was another study which was done recently, and they had shown some quality of life improved in all the 12 patients. But that was basically was done in OPMD patients, oculopharyngeal muscle dystrophy, not actually directly in DMD. तो DMD की स्टडी में 5 बच्चों में दिया था, तो उसके अंदर यही देखा है मसल ड्राइव वाले में कि थोड़ा जो मसल बायोप्सी वाले के अंदर में थोड़ा इम्प्रूवमेंट है. तो अभी बहुत दूर है बिफोर वी कैन डू. अभी stem cell therapy VTA 110 NANMED has been given a FDA orphan drug for treatment. तो उसके अंदर this is being potentially treated as a first in class of the allogenic iPSC based therapy. तो ये जो stem cell based है, ये iPSC induced प्लूरिपोटेंट स्टेम सेल्स का, ये VTA 110 इसका ऑर्फन ड्रग स्टेटस दिया है और USA में इसका स्टडी चल रहा है. हमारे यहाँ एम्स में पूजा ने PhD किया था विद डॉक्टर सुजाता मोहंती. हम लोगों ने उस समय हमारे बच्चों को जो हम स्किन बायोप्सी कर रहे थे, वो स्किन बायोप्सी वाज गिवन टू हर, एंड उन्होंने उसके अंदर से iPSC बनाया है. So we have had this PhD student with Dr. Sujata Mohanty, and from the studies which we were doing and in which we were doing from the skin biopsy, trying to stain and do, we also gave the skin biopsy to them, and they have produced iPSCs from that. But it is a long way from actual being used in practice. Nowadays, something more is coming up besides a stem cell is MSC derived exosomes, which are being tried for various conditions, including the myogenesis. So these are all something about the future. तो मतलब mesenchymal stem cells जो हैं उसके अंदर का भी पार्ट है एक्सोसोम, उसकी भी थेरेपेटिक इम्प्लीकेशन पे स्टडी चल रहा है, जिसमें से वन ऑफ द स्टडीज ऑन द मसल्स. This is an Exon map explorer app which you can download, and when you put the genetic mutation of what you have got in your child, the patient you have seen, then you can understand whether the child is amenable to any treatment ongoing. So this app is there in which we'll can come to know. तो ये ऐप में से हमें पता चल जाएगा कि बच्चे में जो भी जेनेटिक डिलीशन है उसके लिए अभी एमिनेबल है कि नहीं, क्योंकि ये 51, 45, 53 इट डजेंट मीन कि वो एक पर्टिकुलर, बट दे आर वेरियस pairs and groups of gene mutations with genetic mutations which are amenable. So all DMD patients are not amenable, and only few of them, but which specific ones can be seen by the app, and there are also many other copies are available. Maybe we will put it on our website also. Actually, during this course of the Global Gene webinars, we'll be putting one Global Gene webinars. We'll be putting on our website one separate folder on that, and on that we will put all these also. So we will put the there's a PDF of a Word document, in a PDF of a document in which you can see which all pairs are amenable to what exon skipping. तो exon skipping के related या तो ऐप से हो सकता है या हम उसका material अपनी वो website में डालेंगे. Abhi, this is something very important, available drugs and their current status. So Exon is 51, FDA approved, and basically it improves dystrophin जो production है वो improve करता है. 6-minute walk test is also improves, and it stabilizes cardiac and respiratory decline. So with 51, we have improvement in the production as well as some functional improvement. तो एक्सॉन्डिस 51 जो एफडी अप्रूव्ड है उससे अंदर डिस्ट्रोफिन का प्रोडक्शन भी दिखाया गया है और उसका जो फंक्शनल वर्क करता है बच्चा और कार्डियक और रेस्पिरेटरी जो डिक्लाइन होता है उसको थोड़ा कम किया गया है. इसमें ज़्यादा मैक्सिमम स्टडी हुई है. कमिंग टू 53 विच विल बी गोल्डिरार्सन एंड वाइटोलॉर्सिन, एंड in that situation you have exon skipping for 53. इसमें they have just shown increased dystrophin production and some improved vital capacity time functional in the वाइटोलर्सन. कोल्डिरर्सन में सिर्फ dystrophin production दिखा है increase, और वाइटोलर्सन में उसके थोड़ा सा improvement functional capacity में दिखा है. कैसिमर्सिन is 45 and उसका सिर्फ safety has been shown to be okay in children. 45 has only safety been shown, and ataluren they have shown their dystrophin production also and improvement in 6-minute walk test. So ataluren has shown okay dystrophin production भी बढ़ रहा है और उसका movement भी जो है उसका walk test में भी improvement बढ़ रहा है. Basically इसमें they are all weekly infusions except for ataluren, which is an oral drug which is given, and सबसे थोड़े side effects are there. They're not very much significant side effects as what we have seen so far in the entire trial of the PTC thing. We have not seen much significant side effects, and but the last column is very important, that because of for a 30 kg child the cost of these drugs annual is like 6.8 crore for 51 and 53, and for Vitolursen is 8 crore, and 45 it's 6.8 crore, and basically ataluren is around 3 crores. So basically all these are very prohibitively costly. So basically we have to understand कि इन सबका जो weekly infusion है सिर्फ ataluren was oral medication, and the cost for a 30 kg child देखो 6 से 8 crore है और ataluren का 3 crore है. तो basically how do we go about it, कितना patients में benefit है, to understand and rationally give this and how to have it available is very important, and to understand it's a matter of debate. Coming to the SMA part. The SMA part, SMA was initially described in 1850 and 1890, and then ultimately the gene was discovered in 1992, and then you had the various trials which are going on, and the FDA approved Zolgensma in 2019, and lots of things have come up. So from 1850 में जब वो डिजीज़ बताया गया और उसके बाद SMN1 and 2 डिस्कवर हुआ 1992 में, अब तो 2019 में Zolgensma जो जीन थेरेपी अप्रूव हुआ है, आजकल बहुत सारा कुछ अवेलेबल है. This is a very important slide. As I mentioned to you earlier, SMN1 is going to tell you about the diagnosis, and SMN2 copy numbers are very important because we are going to work on them. SMN2 copy numbers are 1 and 0, 2 in 1, 3 in 2, 3 to 5 in 3, and 3 to 5 in 4. So this is important, and I'll come to know in the next slide why it is important. The SMN2 copy numbers are varying, जो होते हैं ना different SMA types के हिसाब से वेरी करते हैं. इसका प्रेजेंस होना इज़ इम्पॉर्टेंट फॉर बीइंग जो नया ट्रीटमेंट के लिए ऐड करने के लिए हम बात करेंगे. So with an unaffected individual, you have SMN protein coming 100% from SMN1. For the type 1 patient, you are not getting anything from SMN1, but you may have some protein coming from SMN2. ठीक है, तो ऐसे ही 3 and 4 में there is little bit of difference. सो जो हमारा है SMN1 से नॉर्मल बच्चों में सारा प्रोटीन आ रहा है, और जो SMN टाइप पेशेंट है जिसमें SMN1 से कुछ नहीं आ रहा है लेकिन SMN2 से कुछ प्रोटीन आ रहा है अनस्टेबल, वही इससे थोड़ा सा मूवमेंट और पावर है. There's a Cochrane review which was there about SMA type 1, which has shown that nusinersen was effective in a moderately certainty evidence, but trilosol was inconclusive. So Cochrane में बताया है कि जो न्यूसिनर्सिन एक मेडिसिन है उसका मॉडरेटली सर्टन एविडेंस है, उसका मतलब अच्छा एविडेंस है ट्रीटमेंट का SMA टाइप 1. Cochrane another Cochrane SMA type 2 and 3 has shown that nusinersen is beneficial in motor function in SMA type 2 and no effect on motor function of creatine, gabapentin hydroxyurea, phenylbutyrate and valproate and TRH etc. तो न्यूसिनर्सिन का बेनिफिशियली इफेक्ट पाया है टाइप 2-3 में और बाकी सबका कोई इफेक्ट नहीं पाया है. But this is the same slide which is coming again. But this is the most important thing which we have to see for a child: seeing growth, nutrition, pulmonary, cardiac, other systemic evaluation, psychological counseling, pharmacological, physiotherapy, occupational therapy, and special education, and providing some orthotic devices, braces, and support, and ventilatory support things, and musculoskeletal system, of course. This was a slide which we had talked about. ये पिछली स्लाइड में यही है कि मल्टीडिसिप्लिनरी अप्रोच चाहिए जिसके बारे में हम बार बार बात कर रहे हैं. और फंक्शनल क्लासिफिकेशन इज इंपॉर्टेंट फॉर अस टू अंडरस्टैंड द holistic care will depend on non-sitters, sitters, walkers, because based on their functional thing, the complications will be there and the support required. तो basically non-sitter, sitter और walker के हिसाब से हम उनको supportive care दे सकते हैं. So the non-sitters, the supportive care is for neuromuscular and musculoskeletal evaluation, and orthopedic. We have to look at spine deformities, look at the nutrition, look at the constipation, feeding, and follow them up with growth, nutrient deficiencies and all. You have to keep following. तो जो बच्चा बैठ नहीं पा रहा है उसके लिए न्यूरोमसल सिस्टम को देखना है, उसका रीढ़ की हड्डी कैसी है, हिप कैसा है, चेस्ट डिफॉर्मिटी, कंट्रैक्चर्स, ये सब देखना है. एंड देन यू हैव टू लुक फॉर द स्पाइनल पार्ट, देन यू हैव टू सी फॉर anything you need to give any supportive care for the hip. You look for the nutrition, feeding, constipation, all this, and growth and nutrition के ऊपर we have to follow up for the child. Pulmonary thing, you have to look for breathing difficulties and look at maybe required functional need of assisted ventilation may be required. And तो pulmonary function में क्या सांस में प्रॉब्लम हो रही है, कितना noisy breathing है, कितना support चाहिए, that is important. And फिजियोथेरेपी के लिए जो है हमारे को देखना है कि वी हैव टू गिव द orthosis and all, whether you need to give any cervical bracing, you have to give stretching exercises, positioning, chest physiotherapy, dietitian, pulmonologist, referral psychologist. All this is very important. So you need to understand this, कि all these things have to be taken in care of. All these things have to be taken in care of while we are waiting for any definitive cure as well. This is important. मतलब हमारे को सिर्फ वो मेन डेफिनेटिव के बारे में नहीं चेस करना, हमारे को ये सारी चीज़ों को सपोर्ट करना ही है. फिर हम उसके बाद ही उसके ऊपर कोई डेफिनेटिव केयर होने के बाद भी रिस्पॉन्स आएगा. They have to be followed up and given the gastric esophageal reflux mechanisms and all that. And for these small children, it is important to understand that when do we stop the proactive approach. If you are having a problem, if these children are having bulbar dysfunction coming up and all, and that is important to understand when you go towards from proactive to palliative care, and what are the ethical issues and what are the parental expectations. So this is very important. बेसिकली रिफ्लक्स वगैरह की प्रॉब्लम देखने के लिए करना है और कैसे हमारे को कि पूरा डेफिनेटिव क्योर के हिसाब से देखने के तरफ से कब हम पैलिएटिव की तरफ सोचें. जब हमारा बच्चा ज़्यादा एडवांस हो गया है, जब उसका सारा वीकनेस हो रही है, बल्बर वीकनेस हो रही है, बहुत वीकनेस है, सांस में प्रॉब्लम हो रही है, वेदर वी शुड गो टुवर्ड्स पैलिएटिव केयर. तो ये बहुत इंपॉर्टेंट एक एथिकल इशू रहता है. Palliative care is acute holistic care of an individual across all ages with serious health related suffering because of severe illness and especially those near end of life. तो जो बच्चे को ज़्यादा प्रॉब्लम है जिसका हमें लगता नहीं है कि सुधार हो सकता है, तो हमारे को उसको बिल्कुल डिग्निटी एंड रिस्पेक्ट उसको पूरा सपोर्टिव केयर देना है ताकि वो बिल्कुल कंफर्टेबल रहे, पेन फ्री रहे जितना हो सके. Coming to the next group was sitters. Sitters again, then there is a problem which adds, they'll have more scoliosis. Back problem ज़्यादा बढ़ जाती है इनमें. So we have to look at the cob angle and we have to monitor and maybe provide them spinal orthosis and surgical stabilization may be required. तो जो बैठने वाले बच्चे हैं उसके अंदर स्पाइन का इशू के ऊपर ज़्यादा देखना है. Coming to walkers may be neuromuscular and musculoskeletal evaluation and orthopedics has to be kept in mind, and nutrition. So walker we understand कि ये सारा चीज़ें चलेगा. The important comes in transitional care when these children also become bigger and have become adolescent and going into adults. We should provide a proper planned transitional care to adult neurologists. तो adult neurologist को transitional care देना है. तो हमारे को जो whatever the parents ask, we have to have queries have to be answered. So we have the PIS on our websites which are there, which you can see. हमारे PIS में आप देख सकते हैं. We can't Very important to do a genetic counseling for all of them. Autosomal recessive है, risk of recurrence risk 25% होता है, both the parents are carriers, and it's important to understand the carrier status, and बाद में we can do the prenatal testing by amniocentesis and CBS. That's all what I want message to go. कि it is autosomal recessive है तो 25% में recurrence risk है कि दोनों parents carrier हैं. Carrier status important है देखना, और amniocentesis और CBS से करते हैं कि whether the child is affected. Overall, हमारा जो carrier frequency is 1 in 40 to 160, which Asians have a higher carrier rate. So there is a debate going on whether you can do a newborn screening, whether it's feasible, and all that is something वो debate है. Carrier frequency high है, the debate is still on. This is a very important thing. SMN2 is a backup gene. So SMN2 producing only 10 to 20% of the working protein as compared to SMN1. तो ये हमारा जो बैकअप जीन है, जो मैंने पहले एक स्लाइड में दिखाया था कि नॉर्मल में 100% तो आ रहा है वहाँ से, लेकिन 20% तक का आपको SMN1 से है. सो व्हाट इज हैपेंड इज इन द हेल्दी इंडिविजुअल protein, everything is coming from SMN1, and SMN2 there is a substitution by C2T, so the exon 7 gets deleted, so there is an unstable protein, right? And an SMA, when you do not have this SMN1, right, then again your C2T substitute is the, and then you get exon 7 is deleted, so you get an unstable protein. So now almost except the gene therapy, both the nusinersen and the risdiplam are acting on this SMN2. वो क्या कर रहे हैं, that SMN2 में obviously you have a C2T mutation, so we are identifying potential therapeutic strategy in which you can prevent this splicing and prevents the exclusion of exon 7. So जो आपका risdiplam और nusinersen है, that is affecting on this, that it is preventing कि जो exon 7 delete हो रहा है उसको delete होने ना देके उसको incorporate होके एक functional protein बने. That is what is important. Nusinersen was FDA approved in 2016 for all types of SMA and SMN2 directed ASO. Antisense Oligonucleotide is given intrathecally. 4 loading doses. First 3 are at an interval of 14 days and the fourth is 30 days after the third dose. So 1.5 months plus 30. 2.5 months you will get the loading. And maintenance is 4 monthly lifelong. It may cause thrombocytopenia and all, but we have not seen many side effects in this. तो इसको रीढ़ की हड्डी में देना होता है और 2016 में अप्रूव हुआ था. पहले 4 लोडिंग डोज हैं और उस 2.5 महीने के ऊपर, उसके बाद 4 मंथली लाइफ. ज़्यादा साइड इफेक्ट ने देखे नहीं है, हम लोगों ने भी रिपोर्टेड है प्रॉब्लम, तो इतना साइड इफेक्ट नहीं है. इसमें वो सेम थिंग इज बीइंग डन, दैट दिस इज प्रिवेंटिंग, दिस ASO इज प्रिवेंटिंग द एक्सक्लूजन ऑफ 7, तो 7 इज गेटिंग included and it's becoming as a sort of active protein. And there are various trials which have shown that early treatment is going to maximize the benefit and motor function will दें. जितना जल्दी देंगे उतना अच्छा motor function होगा. And they have done studies in those less than 6 weeks of age to get benefit. Less than 6 weeks में भी benefit दिखा. And there have been also studies in which they have already got Zolgensma and then they tried nusinersen. Their things are preliminary, but they are all beneficial. Coming to gene therapy, इसका ये वाला था, हमने बात किया था कि nusinersen के अंदर वो exon 7 डिलीट नहीं हो रहा बिकॉज वो वहाँ पे जाके चिपक के बैठ रहे हैं, तो वो 7 को इंक्लूड कर रहा है. एंड उसके बाद वेरियस ट्रायल्स हैव शोन हर एज के बच्चों में, डिफरेंट छोटे बच्चों में किया है और लेस देन 6 वीक्स में भी किया है, और जिसमें फंक्शनल इंप्रूवमेंट अच्छा हो रहा है. And next coming to Zolgensma, which is a gene therapy. It was approved in May 27, 2017 as the costliest medicine as a single dose. But I think it has been surpassed by one more medication recently, another new gene therapy which has come up last year. And this was approved for less than 2 years of age of SMA. But mind you, total cost of treatment with nusinersen during a child's life is more expensive than it produces a working SMN protein, does not change or become part of child's DNA. तो ऑलरेडी 2017 में अप्रूव हुआ था, सबसे महंगी दवाई थी. अब थोड़ी एक और दवाई से और महंगी निकली है थोड़ी सी, लेकिन 2 साल से कम की उम्र में बच्चों में इसको किया था. पर ये मानना रखना है कि ये 1 टाइम है और बाकी जो दवाइयाँ हैं वो लाइफ लॉन्ग है. तो अगर हम nusinersen का जो कॉस्ट लगाएंगे पूरी लाइफ का, वो मोर एक्सपेंसिव आएगा ओवरऑल अगर सिंगल डोज Zolgensma से, प्रोवाइडेड सिंगल डोज विल वर्क, राइट. एंड इट इज़ प्रोवाइडिंग जो SMN प्रोटीन को प्रोवाइड कर रहा है, लेकिन वो बच्चे के DNA में मिक्स नहीं हो रहा. इट इज़ प्रोवाइडिंग थ्रू द वेक्टर. What is happening is SMN gene is put in the vector AV9 and then it is being put into the patient. And then you are making. So AAV9 वेक्टर से वो अंदर पेशेंट में आ रहा है. It is given on a intravenous infusion over 60 minutes and you prime with steroids 1 day before and you may need to give it from 1 to 6 months and you may have alteration in OTPTs and thrombocytopenia and tropi may be elevated. And इसके अंदर वन इन्फ्यूजन है और उसका एक इन्फ्यूजन है, एक दिन पहले से स्टेरॉइड चालू करते हैं और स्टेरॉइड हमें 1 महीना से 6 महीना तक भी दे सकते हैं. 1 महीने तक के लिए लिखा है लेकिन उसके आगे डिपेंडिंग ऑन द चाइल्ड्स रिस्पॉन्स, क्योंकि उनके अंदर लिवर फंक्शन एंजाइम डिलीट हो जाती हैं, प्लेटलेट काउंट कम हो जाते हैं. एंड इनको अप्रूव कराने के लिए स्टडीज़ करी गई हैं जिसके अंदर बेनिफिट शुरू किया है, कंक्लूसिव बेनिफिट शो किया हुआ है कि 91% ऑफ पेशेंट्स वर अलाइव एंड डिड नॉट नीड परमानेंट ब्रीदिंग सपोर्ट एंड 14 and 18 months ऑफ एज. तो छोटे बच्चों को जो इनको दिया था उनका 14 और 18 months में 91% को कोई परमानेंट ब्रीदिंग सपोर्ट नहीं चाहिए था. 59% कुड सिट विदाउट हेल्प फॉर एटलीस्ट 30 seconds. तो इसलिए दिस ऑल हैव शोन सिग्निफिकेंट बेनिफिट एंड 100% of patients were alive and did not need permanent breathing support. So most of these studies have shown significant improvement in the motor and need for respiratory thing. So जितना जल्दी देते हैं the earlier the given the early better response. So they have shown improvement. दिखाया गया है कि सबका मोटर जो है फंक्शन इंप्रूव होता है, रेस्पिरेटरी सपोर्ट का रिक्वायरमेंट कम होता है. सो ये सारा वेरियस स्टडीज ओवर अ पीरियड ऑफ टाइम दिखाया जा रहा है. एक लॉन्ग टर्म स्टडी में दिखाया है कि अगर छोटे में बच्चे को दिया जाता है, जल्दी बच्चों में दिया जा रहा है, तो उसके ये क्या है कि उसमें उन्होंने देखा है कि 100% ऑफ पेशेंट्स वर अलाइव एंड डिड नॉट नीड एनी ब्रीदिंग सपोर्ट ऑन अ लॉन्ग टर्म फॉलो अप. तो इसलिए इट इज़ सीइंग दैट इम्पॉर्टेंट दैट दे have much improvement. But there's an issue. अब वो it is not incorporating into the gene, the DNA. It's just giving a functional protein, whether it's going to last lifelong. And you actually can't give it again because once you develop AAV9 antibodies, you can't give it. So whether we will need to give it, there's a long-term study going on for 15 years from February 2020 to 2035 and trying to see whether this long-term advocacy is there or not, because as of now we have results only for 5 years. तो 5 साल तक का ही स्टडी अभी अवेलेबल है, 15 साल का स्टडी चल रहा है, क्योंकि अगर आपको एक बार दे दिया है AV9 के अंदर तो हमारी बॉडी के अंदर AV9 एंटीबॉडी बन जाएगी, तो हम दोबारा नहीं दे पाएंगे. अगर अभी ये 15 साल का स्टडी बताएगा क्योंकि हमारा वो DNA में इनकॉर्पोरेट नहीं हो रहा, सिर्फ फंक्शनल प्रोटीन बना रहा है, तो इसलिए वेदर वी विल नीड इट और नॉट, इफ़ वी नीड इट व्हाट आर द वेज, कहीं हमारे को कोई और वे से उसके एंटीबॉडीज़ को निकाल के कुछ करना पड़ेगा, वो दूर की बात है. मतलब पॉइंट इज़ रिसर्च इज़ ऑन. वी आर नॉट श्योर कि वो लाइफ लॉन्ग चलेगा, अभी 5 साल का डेटा है. तो वी आर शोइंग दैट देयर इज़ अ रैपिड सिग्निफिकेंट मोटर इम्प्रूवमेंट्स फॉर अर्ली वो इन्फेंट्स विद सीवियर SMA व्हेन अर्ली एज. तो उनको दिखाया कि जितना जल्दी देंगे कि उतना इंपॉर्टेंट है. कमिंग टू थर्ड ड्रग, रिस्डिप्लैम. दिस इज़ अ ओरल ड्रग approved by USA in August 7, 2020 and it was approved for 2 months and above and an oral drug. ठीक है, उससे पहले यूरोप वगैरह में पहले ही हो गया था. For Europe and all it was already done. This is an oral drug which is there, again a selecting SMN2 splicing modifier. Mechanism of action इसका वैसे ही है जैसे हम बात हो रही थी for nusinersen, right? And it is same way it is causing inclusion of the exon 7 ताकि functional protein हो. So it causes inclusion of exon 7 so that you get a functional protein. And you have a dosage schedule based on the age, and 2 months to 2 years you have 0.2 mg per kg, 2 years of age and older weighing less than 20 kg is 0.25 milligram per kg and more than 20 kg is 5 milligram. It's given in an amber colored glass bottle and it has to be reconstituted by doctor. तो एज और के हिसाब से उनके डोजेस हैं. ओरल सस्पेंशन है, आपको उसके अंदर जो वाटर फॉर इंजेक्शन मिला के देना है वो डॉक्टर ही बना के देता है. उसके बाद आपको टेम्परेचर वगैरह को मेंटेन करना होता है. सिग्निफिकेंट साइड इफेक्ट उसमें हम लोगों ने देखे नहीं है पर कुछ रिपोर्टेड है. एंड इसका भी जो स्टडीज़ हुआ है, इसका बेसिकली वी हैव हैड 4 studies which have been there and the evidence has come from 4 studies. It was approved by FDA, I mentioned, in 7th August 2020. And there was a study of firefish in which they did for 2 to 7 months years, and then your sunfish was done in 2 years to 25 years. So in all of them they have shown motor improvement. Okay, so there was and then all of them, and the younger they started treatment, the better it was. So all these patients have their studies, they have shown this, that the earlier you start, and the latest has been this rainbow fish in which they have done from birth to 6 weeks. सो इसमें बिफोर प्रोसीडिंग फर्दर मैं आपको हिंदी में भी बता देती हूँ कि बेसिकली इसके अंदर 4 मेन ट्रायल हुए हैं और दिखाया है कि हर एक में इम्प्रूवमेंट हो रहा है, बच्चे के मोटर पावर के अंदर इम्प्रूवमेंट हो रहा है। और सबसे लेटेस्ट स्टडी जो है वो है रेनबो फिश है कि बर्थ से लेकिन 6 हफ्ते में, क्योंकि अप्रूवल पहले 2 महीने से ऊपर का था। ये वाला जो ट्रायल है उसका जो अभी स्टडी जो आया है, द ट्रायल विच हैज शोन दिस फ्रॉम बर्थ टू 6 weeks, they showed that most of the infants treated for at least 12 months achieve motor milestones within the WHO window for healthy children. मतलब if they were given in the first 6 weeks, बच्चों को दिया है ये दवाई से चालू किया है, तो फिर वो 12 महीने पे जो उनके मोटर माइलस्टोन एक बच्चे के होने चाहिए नॉन SMA के जो ठीक ठाक बच्चा है उसी की तरह से। So there have been these 4 studies which have shown and proven its benefits, and abhi in January 24th 2022 Gentex Evercity was granted FDA priority review for treatment of pre-symptomatic babies less than 12 months of age also, pehle because it was being done only for 2 months and above. This is a very important slide. Intrathecal Spinraza 4.2 crores per year first year and the 2.1 crores thereafter, because first year you have a 4 loading doses also, then 4 monthly lifelong. The Zolgensma was 16 crores one single time, and we do not know, we have the data till 5 years ki theek hai. And then this was approved Zolgensma for less than 2 years. Right now we have another trial coming for 2 to 18 years. I'll just be showing one slide. I'll be winding up in 2 minutes. For Isdiplam, it is for a 20 kg child, 2.5 crores per annum. And then Roche has given some package to Indian parents through the various NGOs and parent support groups, and that comes around 1.4 crores per annum roughly, because they have some 1 bottle buyback, 2 bottles, something like that. From that, if you make a rough estimate, तो मतलब स्पिनरजा का 4.2 करोड़ पहले साल में एंड 2.1 करोड़ देयर आफ्टर, और जोलजेस्मा का 16 करोड़ एक ही बार का है, पर उसका वैसे लाइफ लॉन्ग रहेगा कि नहीं वो पता नहीं अभी, एंड अभी तक तो सही है। और रिजडीप्लाम का 2.5 करोड़ पर एनम है ऑन द रेट्स विच आर ऑन द इंटरनेट, बट द कंपनी बिकॉज इट वॉज लॉन्च्ड इन इंडिया इन जुलाई 2021. It was launched in India and it was after DCG approval, Risdiplam. That's the only one which is launched. And then after it's launched, they are giving some package benefits to parents who are purchasing, and that is coming 1.4 crores. तो अदर ड्रग्स हैं, बहुत और ड्रग्स चल रही हैं, बस आपको बस मेंशन कर रही हूँ। बनानालाप्राम चल रहा है, एक और भी नया है एपिटोग्रुमैब, और अब लोग दे आर टॉकिंग अबाउट combinations. They're talking about combinations, whether you can include SMN1 delivery, collecting the spicing wala jo nusinersen and Risdiplam we were talking about, or increasing the expression of SMN2 by histone deacetylase inhibitors. On that, which were valproate and all were being tried earlier and had failed alone. Whether they all can work and have help in a patient is something, but these are all anyway very, very expensive drugs, so I do not know. But whether the cheaper ones can be added and supporting provide, that is something which is to be thought about. So basically combinations ka hai chal raha hai, whether we can do combinations. This thing is regarding SMM stem cells using viral vectors to replace SMN has shown to decrease motor neuronal death and increase lifespan in mice model. तो एविडेंस है, सिर्फ अभी माइस मॉडल में है कि कुछ न्यूरोनल डेथ को जो है वो कम करेगा, अभी इट इज़ वेरी फार अवे. So humanitarian access programs, which we were asking, we've had 3 humanitarian access programs. We had Spinraza, they had asked us in 2 cycles. Once they had asked us in April 2019, they asked for Indian sites to give, and that time we were allotted 13 patients out of maybe a 30 total they agreed, they gave. In the next slot was in last year, was in 2021 March beginning, and there they had selected 200 patients from pan India, and we had our 38 patients got selected. So we have had experience in 2 lots for them. I'll just be giving you one slide of one patient. Second is Zolgensma. So currently there is no new recruitment on, but they may come up. They have promised to give it lifelong for these patients. And second thing is, second drug for Zolgensma, you're having a global access program going on globally. Anybody can apply, and but that is for less than 2 years. Okay, तो ह्यूमैनिटेरियन एक्सेस जो स्पिनरजा वाला था वो उसका कुछ स्पेसिफिक एज और गाइडलाइंस था, थोड़ा बड़े बच्चों में कर दिया था फॉर द सेकेंड टाइम, बट वो अभी ऑफ है न्यू रिक्रूटमेंट. Zolgensma recruitment is only on less than 2 years. So they are having lottery every 2 weeks and then they take a call. And for Risdiplam, they had a humanitarian access program before the drug was launched in India. After that, they're not taking any more news. So we've had some experience. तो उनका बारे में I will be just talking about it. And besides that, we have had one patient of Exon 51 who had received, but he had nearly become, by the time they had arranged my funds to, procure the Exondys, he had become nearly non-ambulatory, so he did not get much benefit. With PTC, we have had our 11 patients who have been included. We do not know how many got the drug, but 11 were there. तो फिर 11 पेशेंट्स तो हमारा कंप्लीट हुआ है और एक्सॉन स्किपिंग 45, 51, 53 के लिए हमारे पास इस वक्त 2 ट्रायल हैं। एक हमारा एक इंडिजिनस इंडियन ट्रायल है फ्रॉम डार्ट, दे आर प्रोड्यूसिंग इंडिजिनसली इंडियन antisense oligonucleotides and उसका भी logistics are being worked out and recruitment अभी start नहीं हुआ, we'll put it on the website. Second is from Sarepta. Sarepta has come up with 2 trials for covering all the 3, 45, 51 and 53, and they are taking various approvals. So these 2 trials will start simultaneously at many sites including ours. And regarding SMA, I had done one RCT on gabapentin, which was negative lots of years back. And I also did another RCT on levocarnitin along with valproate. That was also negative. This was the SMA patients. I have already given you the thing. Regarding Zolgensma, 10 patients have been given Zolgensma, and one has got through crowdfunding and one got from Employees Health Scheme from Coal India, and one has got approved last week. So we'll be getting it this week or early next week. Regarding nusinersen, we have had 13 patients selected earlier, out of which 1 died before the medication came to us, and 38 were taken in the second cycle. And risdiplam, 7 are getting from Humanitarian Access and 2 are getting paid through crowdfunding. So out of, I just wanted this slide to show that even after the first 4 doses, some improvement in functional scores were there in all patients. And for SMA type 1, their respiratory infections became less, improved activity, reduced irritability. तो आउट ऑफ ऑल द पेशेंट्स जो है तो इसमें हर एक में थोड़ा थोड़ा इंप्रूवमेंट आया है। SMA 1 में रेस्पिरेटरी कंप्लेंट्स कम थी। सो दिस आर फ्यू वीडियोज ऑफ वन पेशेंट ऑफ ईच आई एम शोइंग। दिस इज द चाइल्ड हु वाज गिवन द फर्स्ट डोज ऑन 2nd of January 2020 after getting the 4 loading doses. After getting the 4 loading doses, that took 2.5 months, and then there was a 4-month gap when he came for maintenance. Yani 6.5 months from the first dose, the child could pull herself from sitting to erect position. तो मतलब 6.5 महीने में after first loading के 4 dose उसका ये improvement आया. This I had just shown, अगर वीडियो नहीं चले करके, that's how. And then this child has उसके बाद उसका इम्प्रूवमेंट आया, ट्राईसाइकिल चलाने लग गए, उसके सारे एक्सरसाइजेस कर रहे हैं बाकी, एंड द चाइल्ड इज नाउ ट्राइंग टू एबल टू स्टैंड ऑल्सो अपने आप। एंड अभी क्या है, नेक्स्ट स्लाइड देखते हैं। नेक्स्ट स्लाइड में अभी द चाइल्ड इज एबल टू वॉक विद द वॉकर, भी वॉकर के साथ चल पा रही है। सो it is not magical, but there is a significant improvement. This is what I want you to understand. मतलब कहीं, because अभी recently मैंने कोई patients को देखा, they are expecting magical cure. So it is not magical. Things improve, but it is going to take time. This is a second child who would transiently sit. हल्का मुल्का बैठ सकता था अगर बैठाते और गिर जाता था। उसके बाद वो मेंटेनेंस फर्स्ट के बाद वो सपोर्ट के बिना खड़ा होने लग गया, and he would raise his arms up to the ear level. And this is the last one, is for a child who was SMA type 1 who got selected in first time, and that time the child could lift the elbow from the ground and could hold these toys. Utna he could not do, and respiratory infection kam ho gaya. So everybody, depending on the severity, had the improvement. Gene therapy we had done, as I mentioned to you, 10 mein ho gaya hai, and they were type 1 and 2, and the first child we had done on 29th May 2020. That was the first patient in India who had gone gene therapy, and the child could not even hold head completely without support. Uske baad, now the child is able to stand with gaiters. So at 21 months post therapy, the child is now independently sitting and standing with gaiters. This is with providing holistic multidisciplinary care, looking after nutrition, OTPT, gaiters, everything, and all whatever support is required. For Advocacy, I mentioned to you about those patients. So we have had to, most of them were type 2. So this child, she could bear weight on 4 arms, and after 5 months the child could bear weight on extended arms, and then after 8 months could ride a seesaw, could be able to feed with spoon without spillage, and then could at 13 months attempts to hold knee chest position, sits independently, plays with toys. And so they are having definitive improvement, lekin it's magical nahi hai. This is the trial which is going to start, which is 2 years to 18 years, single intrathecal. It will be intrathecal, वो सारा intravenous था, this will be intrathecal, रीढ़ की हड्डी में देंगे. And उसके बाद there is also another study going on in which Novartis is trying to see really ये जो सारे humanitarian access programs, all of them which is going on in the real case scenario, in the real world, what is the benefit for these children. We have to remember, when do we suspect, अर्ली डायग्नोसिस है, कब पकड़ना है, सस्पेक्ट करना है, होलिस्टिक मल्टीडिसिप्लिनरी अप्रोच एंड ऑप्टिमाइज ट्रीटमेंट, genetic counseling and prenatal diagnosis, very important, neurotherapeutic options, and besides physical therapy, but cost are prohibitive. We'll be debating either how to get and what is the research going on to produce indigenous molecules. All that will be discussed in the future webinars. This is the most important slide still to see about the multidisciplinary approach. And patient information material is very important. You can access from our www.pedneuroaims.org. Hope is a powerful emotion and an incredibly positive one. So hope बहुत important है, but it should never be used as an excuse for shortcuts in pursuit of quality. Evidence पूरा generate करना है of the research for the benefit of children now and for the field to advance in future. Shortcuts कुछ नहीं है. Research takes time, and we're very grateful to all the children and families who have given us the opportunity to treat them, and we're grateful to you for having joined online in the first 2 of these talks in the series we have. We're very happy to answer any questions. Over to you, Dr. Kakuri.
Thank you, Dr. Shefali, for expressing all the things so nicely, both in Hindi and both in English. I think many of the patients might have benefited. इतने सारे तरीके बताए हैं, इतने सारे दवाइयाँ बताया है कि किस तरह पे, किस स्टेज में, कहाँ पे हम एनरोल कर सकते हैं, किस तरह से लाभ ले सकते हैं, वो बहुत ज़रूरी है. और हम लोग जितना भी इसके बाद में हमारे और भी 18 वेबिनार्स है जिनमें कि हम लोग कवर करेंगे अलग-अलग चीज़ें, जिनमें से मेन होगा कि न्यू ड्रग ऑप्शंस क्या-क्या हो सकती है, एथिकल इश्यूज़ किस तरह के होंगे, हम पेरेंट सपोर्ट ग्रुप का भी को भी इंक्लूड करेंगे ताकि वो लोग भी अपनी राय दे सके. हम लोग प्रोहिबिटिव कॉस्ट मेन है, जो डॉक्टर शिफाली ने लास्ट में जो स्लाइड से शेयर किए हैं, विच वर वेरी इंपॉर्टेंट एंड विच शोड द कॉस्ट इज़ वेरी ह्यूज. तो हम लोग इसमें फाइनेंस को भी लेके बहुत चर्चा करेंगे. काफ़ी सारे हमारे जो वेबिनार्स है, सीरीज़ है, सेशंस है, वो फाइनेंस को लेके भी चर्चा में रहेंगे, जिसमें काफ़ी मिनिस्ट्री के लोगों को लाएंगे, काफ़ी सारे पॉलिसी मेकर्स को लाएंगे, जो कि आपको ये बता सके कि फाइनेंस किस किस तरह से लिया जा सकता है ताकि आपके बच्चों को मैक्सिमम बेनिफिट मिल सके. क्राउड फंडिंग के बारे में भी बताएंगे आपको, एंड पूरे दुनिया में किस तरह से अप्रोच किया जा रहा है, किस तरह से फाइनेंस रिलेटेड चीज़ों को टेक केयर किया जा रहा है, वो सब चीज़ें भी बताएंगे. अभी हमारे स्क्रीन पे वी कैन सी 2-3 क्वेश्चंस व्हिच आर देयर. आई विल पुट द क्वेश्चंस. मैम, डॉक्टर शिफाली,
लिंक, सेशन लिंक.
पहला क्वेश्चन हम लेते हैं जो कि डॉक्टर शिफाली, आई रिक्वेस्ट यू टू आंसर. दे हैड आस्किंग कि हाउ डू यू हेल्प ओबीज नॉन मोबाइल डीएमडी एसएमए टाइप 3 पेशेंट्स इन वेट रिडक्शन, मेनली टू ईज एडीएल केयर.
बेसिकली इसीलिए बोला न्यूट्रिशन एंड एडवाइस. पहले तो हमने बढ़ने नहीं देना, बढ़ गया तो फिर उतारना और मुश्किल हो जाएगा ना, बिकॉज इट विल बी वेरी डिफिकल्ट. यू रियलाइज़ कि हम लोग ना वेट लॉस करने में मुश्किल होता है, हम चल फिर रहे हैं, तो अभी जो नहीं चल पा रहा उतना उनके लिए मुश्किल हो जाता है. तो इसलिए वी विल हैव टू डू इट फ्रॉम अ diet. Will have to be careful, we'll have to be very careful, we'll have to make a diet, will have to be taken care, and obviously OTPT तो चलेगा साथ में, and whatever if ambulatory exercise plan along with it जितना maximum कर सकते हैं, we'll have to be doing that will have to be seen. and अगर वो steroid पे है then it can be changed to Deflazacort. दैट वुड बी इम्पोर्टेंट। एंड वो SMA वाले तो खैर नहीं होते उसमें, तो यही है, पता है शुरू से यही रहता है कि वी हैव टू बी वेरी केयरफुल टू प्रिवेंट वेट गेन फ्रॉम द बिगिनिंग, क्योंकि बाद में आपको उठाना मुश्किल होगा एंड उसको अपने आप को भी उठाना मुश्किल होगा ना, कि उनको भी प्रॉब्लम होगी विद वीकनेस। सो बोथ वेज इट इज़ इम्पोर्टेंट, एंड बोथ डाइट एंड एक्सरसाइज। या
किसी ने सेशन के बारे में भी पूछा है, क्या क्या टॉपिक्स कवर करेंगे, जो कि हमने अभी अभी डिस्कस किया है। फ्यू ऑफ द टॉपिक्स वो हम बिल्कुल सेशन का हम लोग लिंक भी शेयर करेंगे। अभी नेक्स्ट सेशन हमारा 17th को है, सेम टाइम पे शुरू करेंगे हम लोग। एंड इस बार थोड़ा सा सेशन ड्यू टू टेक्निकल ग्लिच थोड़ा सा डिले हुआ है, बट नेक्स्ट टाइम वी विल टेक केयर कि हमारा सेशन टाइम पे शुरू हो एंड यू पीपल कैन बेनिफिट फ्रॉम दैट। एंड पूरा सीरीज जो है हमारे सेशंस का, हम लोग वो उसका लिंक डेफिनेटली अभी थोड़े देर में शेयर कर लेंगे। नेक्स्ट एक क्वेश्चन है मिस साक्षी का। I am a myopathy patient. I have taken medications and consultation till age 9. I am 23 years old now. I got aware I got aware about rare diseases and I want to continue my medications and therapies. Whom should I consult? Pediatric neurologist or adult neurologist? Is there any association for muscular dystrophy patients who support us in sensitization specifically in rural areas? Dr. Shifali Gulati, kindly आप आंसर करें।
साक्षी, मायोपैथी भी ना डिफरेंट टाइप्स की होती है, तो उसके हिसाब से कई रिसर्च इज़ ऑन। मैं तो हमने DMD और SMA पे फोकस किया था, तो नहीं मैं डिटेल बताए, पर कई चीज़ों के लिए रिसर्च इज स्टिल गोइंग ऑन। तो लेकिन क्या मेडिकेशंस वगैरह दे सकते हैं आप? 23 है ना, तो आपको एक एडल्ट न्यूरोलॉजिस्ट को दिखाना चाहिए। एंड हमारा एक सेशन में हम पेरेंट सपोर्ट ग्रुप्स को लाएंगे साथ में, सो यू विल बी एबल टू बी अवेयर कि क्या है। अभी डॉक्टर काकुली ने आपको बताया ना, एक हमारा 17th को है, बिकॉज 15th अगस्त वगैरह आ रहा है, थोड़ा गैप है, बट बाद में उसके बाद काफ़ी फ्रिक्वेंटली होंगे। तो बाकी सारे विल बी फिनिशिंग बिटवीन today and 3rd September. So it will be, and we will be telling about the next session, and we'll be probably giving the whole list also probably next time.
एक और क्वेश्चन मुझे दिख रहा है जहाँ पे मिस माधुरी ने क्वेश्चन किया है कि सेम एक्सॉन डिलीशन, इज देयर वेरिएबिलिटी इन प्रोग्नोसिस बिटवीन डिफरेंट पेशेंट्स? डॉक्टर शिफाली, कैन यू प्लीज टेक द आंसर?
या वो डू यू रिमेंबर कि हमने बताया था कि कुछ स्टडीज़ में था कि उनका 6 मिनट वॉक टेस्ट जो 300 to 400 मीटर के बीच में था, उनमें रिस्पॉन्स आया था ज़्यादा। तो मतलब जो ऑलरेडी एडवांस है, जो चल ही नहीं पा रहे हैं, उसमें तो उतना नहीं है। तो इसलिए प्रोग्नोसिस जो वो मतलब जो ट्रीटमेंट के साथ जो होगा, पर मतलब इफ यू आर टॉकिंग अनट्रीटेड पेशेंट्स का प्रोग्नोसिस, यू विल हैव टू इंडिविजुअलाइज ईच पेशेंट एंड सी, क्योंकि उसको क्या सपोर्टिव केयर वगैरह दे रहे हैं। एवरी चाइल्ड इज हैज़ अ डिफरेंट ट्रेजेक्ट्री। मतलब अगर आप अनट्रीटेड भी सोच रहे हैं, तो एवरी चाइल्ड हैज़ अ डिफरेंट, मतलब यू हैव अ जनरली जस्ट एन आउटलाइन कि कब तक वो होगा, एंड वेदर वो स्टेरॉइड ले रहा है नहीं ले रहा, विच स्टेरॉइड्स इन ऑल आर नॉट रिलेटेड टू डिलीशन। स्टेरॉइड्स आर जेनरिक, आपको मैकेनिज्म्स ऑफ एक्शंस ऑफ स्टेरॉइड्स हमने दिखाया है स्लाइड में कि उसके डेफिनेटिव है, तो किसका रिस्पॉन्स होगा, तो इसलिए वेरिएबिलिटी रहेगा ही, कौन कब तक चलेगा।
Ma'am, we can see one more question which is there from Mr. Murli. My son is 29-year-old DMD. Can he start steroids now? If yes, how much? And what are the pulmonary muscle care for older boys? How to deal with weakness? Is there any chewable multivitamin specially for DMD? Dr. Shifali, kindly answer.
Yeah. Mr. Murali, we'll be having Dr. Sadish Khadilkar in one of the subsequent sessions, and maybe we can ask her again for that. But what I feel that your child would be non-ambulatory at this time. Obviously, should be started on steroids, but obviously on a lower dose, because as I mentioned to you, when they become non-ambulatory, the lower dose will help improve, maintain pulmonary and cardiac function to whatever it's possible. And obviously you have various pulmonary, and you have to see for sleep related disorder breathing, and you have to obviously having the difference, respiratory muscle training and all, they have to be done for these patients. You'll have to show to an adult neurologist, and then you'll have to have an OTPT can guide you along with this. And I do not know, there are a lot of chewable vitamin C. At least I know about multivitamins. I'm not sure of, but nothing as I know who is for as DMD, and I don't think anything specifically you need for DMD. You can use normal vitamin D, the multivitamin preparations.
Thank you, Dr. Shifali. Miss Madhuri has one more question. What are the anesthetic risk in these DMD patients? Dr. Shifali,
There
can
are
you please
certain,
answer?
yeah, there are certain. Thanks for an important question. The and because there may be a because of the there is a risk, a serious risk with some of the congenital myopathy patients when they have anesthesia and all. They can have a lot of reactions per se, but then obviously here you will be having the problems with that if you are putting them on a ventilator, they'll for any reason, if you want for any reason they have been put, then there will be problem in weaning them out because of their care. But anesthesia risk as such, they'll be not specifically for DMD, but they are for some specific congenital myopathies with those cores. How does
And there is one more question, ma'am, which we can see. Does hydrotherapy helps DMD patients?
hydrotherapy has been tried in cerebral palsy and all and DMD. I mean, there's nothing specific, anything for that you have to get it done. But if the child is feeling comfortable and you're getting, that's okay. But I mean, there's nothing as an evidence-based thing that it is going to help. But hydrotherapy has been tried in CP also and any of the muscle problems and all. So it may help initially. Then obviously later on when the child becomes non-ambulatory, it will not. There's nothing specific for that.
We have one more question from Mr. Murli. If post-spinal surgery and there is an imbalance in neurotransmitters and child reaches treatment resistant stage, what do you do? Dr. Shifali, can you kindly answer?
Spinal surgery is not, there is no such imbalance of neurotransmitters coming up. We have to be just very careful that even in DMD and SMA that they are progressive things, like the problems. So we have to be very clear when we are asking for the surgery and then you are going to ask for immobilization. So there is nothing as such of imbalance of the neurotransmitters which is going to take place for DMD, nothing like that. And there's nothing like treatment resistant because uh, it is a natural trajectory of the disease and you're trying to fight against time and you're going to fight with the various pharmacotherapies and all to prevent and also for the supportive care so as to preempt, all the supportive cares are preempting complications and preventing from them from happening or picking them at the early stages and giving them treatment so as to improve the quality of life.
And Mr. Murli, we are also having few of the pharma companies who will come in our coming sessions who can also tell more about new drugs which will, come or which are in the pipeline. So you can learn from that also a lot about this. If we don't have any more questions.
Yes, somebody.
Madam, can I ask a question?
Yes, sir. Yes, sir. Please. Is this Sunil? Is this Mr. Sunil?
Yes, I am Sunil Kumar, madam.
Yes, sir.
I have three questions. One question is about the repurposed drugs. I heard about that in England and some European countries, they are using some repurposed drugs, like the drugs for AIDS and drugs for the heart, for repurposed for DMD. Is it useful for man?
I have given you the entire thing, I gave you all those anti-fibrotic, everything. So which drugs are being used? There's so many drugs being tried. So they are in the pipeline right now, not available. So I showed that there was various other things, for those anti-fibrotic, for the anti-muscle repair, preventing the muscle damage and all. So all those things they are ongoing. So I just feel, sometimes we just read on the net something. I think we should be able to send to, you can mail to us if there is any query and then we can just check up the evidence and get you back. But it's not like that many drugs have been trying, like, even that corticosteroid replacement drugs which you're talking about, because steroids are causing problems, some problems. So that is why those drugs are being studied. But right now, like this, it's not there, and we should not try them off the because like in India we sometimes get many things available off the counter without prescriptions also. So you should not try on your own, please. But in that case, for any drug, we should either do formally with in trials if they are there, or if it's available, you please go to your pediatric neurologist or adult neurologist. And sometimes something new parents get, we have not even seen sometimes, then we look at its evidence, because you can't know every drug being tried, right? Now these things we have seen on all the CTRI and what all trials are going on. That's why this update has been given. But sometimes something new might be published which might not have noticed, right? So if you have, you please post it to us. We see the evidence, then only it should be given in a proper prescription, because sometimes certain drugs are not approved sometimes. Then we take ethics approval, because if there is no definitive cure for that patient, then we may take an individualized ethics approval before starting those individual drugs also.
Thank you, Dr. Shefali. I'll just add to it, Mr. Sunil, I'll just add to it. For repurposing, there is a long preclinical trial also which needs to be taken care, right? So as soon as so that is why we say, पहले भी जैसे बताया कि काफ़ी सारे ड्रग्स है जो पाइपलाइन में रहते हैं, ठीक है? एक बार जब अप्रूवल आ जाता है, जब हमें दिखता है कि एफिकेसी होता है, तब जाके ये आगे जाके अप्रूवल होता है कि हम क्लिनिकल ट्रायल कर सके इनका, या क्लिनिकल यूज कर सके. आपका नेक्स्ट क्वेश्चन सर.
That is about gas studies. Is it a gas study is useful for the non-ambulatory child? Is it under tent releasing surgery? Is it advisable for a DMD boy, tent releasing surgery and gas studies?
See, whatever is evidence based, I told you, and what tendon release, we should try to prevent contractures. When tendon release also, it's a progressive disease, so it is again debatable whether you want to go ahead and do it. But if suppose it is affecting some important function for the child's quality of life, then you'll go ahead to do it. Otherwise, whatever is under evidence I mentioned, the others are not under evidence. But the tendon release will have to be individualized, and keeping in mind the progressive nature. And then after release, you will also need to keep the immobilization for some time. What is going to be the risk? So let that be decided by your pediatric neurologist, who will take an orthopedics opinion and then do about it, right?
About the gas study.
Which study?
Gate studies.
No.
Gate study.
Gate studies. Okay. No, gate studies are not required. Gate studies are not required.
Okay,
Gate studies are not required. Gate studies are not required because we know that you're having a differential atrophy of muscles, and differential hypertrophy are going to become non-ambulatory. What will we do by gate studies? The gate studies are basically done more for other disorders, and including CP and all, in which we are not sure of which. We have to see what surgery is to be done by understanding what are the problems and what muscles to be done. We do multiple surgeries and during one time, but not for Duchenne muscle.
One question. What is any role of the food supplement like CoQ and other food supplement in the management of DMD? CoQ and other food supplements.
See, I mentioned that these are potential this thing that free radical damage, and also idabenone and coenzyme Q have been tried, but they have been still tried in research mode, and still research is on. I just mentioned they are being studied, so we are not putting it in a normal prescription because the benefit has not been proven. But let me tell you one message important: steroids are still the mainstay of treatment. New treatment भी जिसमें देना, I'm talking about DMD alone. When you're giving they have to be given even when we are going to be able to give or not give the definitive therapies. Whenever definitive therapies have to be given, the children, all for these trials, and even the PTC, somebody had to be on steroid for 1 year. Even for now, those exon skipping trials, they all need to be on steroids for 6 months to 1 year, depending on various trials. So, I mean, that means because those exon skipping drugs are basically adding on to the benefit getting from steroids. So that steroid has a benefit, and just not conjectural matlab. That's why I showed you the slide with mechanism of action.
Madam, one more question is, immunity of the patient is related to the gene therapy or other Exon skipping therapy. I read that if the immunity is high, then the efficacy of this treatment will be sometime low. Is it true, ma'am?
No, this is not a right statement. That what he's talking about is uh, that will not be for this situation. The gene therapy, why will it? The only thing is for like SMA gene therapy is available, you have to do AAV9 titers. If anybody already has an anti-AAV9 titers are already there, then it's a contraindication because in that case it will not function. You're understanding? Otherwise, for the exon skipping, there is nothing like that. And right now we don't have trials for gene therapy or gene therapy available actually on the off the shelf for DMD. So that is all. Anti-AV9 titers being high, the contraindication for SMA Zolgensma because it's being given in the vector AV9. Because if you already have antibiotics, you'll kill it, na? And it will not come.
Thank you, ma'am. Thank you for your kindness.
थैंक यू ऑल फॉर ज्वाइनिंग. होपफुली आपके पास जो
Question.
भी लिंक आया हुआ है एंड यूट्यूब लिंक जो अभी शेयर किया है, काइंडली वो ज़्यादा से ज़्यादा लोगों के साथ शेयर करें ताकि उनको बेनिफिट मिल सके. क्योंकि आने वाले सेशंस में हम फाइनेंस के बारे में काफ़ी बात करेंगे कि किस तरह से आप लाभ उठा सकते हैं. ऐसे ही नहीं बैठे रहिए कि फाइनेंस नहीं हो पाएगा, लेकिन काफ़ी तरीके हैं. जैसे अभी डॉक्टर शिफाली ने काफ़ी सारे चीज़ें बताए हैं. काफ़ी और लोगों को हम लोगों ने इनवाइट किया है टॉक के लिए, जो कि हमें अलग अलग तरीके बताएंगे किस तरह से हम अपने बच्चे के लिए ये थेरेपी ले सके और फाइनेंशियल हेल्प भी ले सके. इसी के साथ हम आज का सेशन यहीं ख़त्म करते हैं. अगले सेशन हमारा 17th को होगा, जो कि वेडनेसडे है. सेम टाइम को हम शुरू करेंगे. हम लोग लिंक और सारी डिटेल्स आगे शेयर करेंगे. काइंडली हमारे साथ लगे रहिए ताकि आप लोग ज़्यादा से ज़्यादा लाभ उठा सके. थैंक यू वेरी मच.
Thank you. Thank you very much.